Good evening. Very warm welcome from Amuseum ArtScience Trivandrum to latest webinar on post-COVID syndrome. Amuseum ArtScience is Amuseum Thoughts for Art Science is a new age concept foundation established in Trivandrum, the capital city of Kerala, India. Amuseum intend to create a knowledge pool based on the convergence of arts and science, creativity, which often deemed as a never meeting parallels. We have a series of lecture presentation, we call it as sharing of thoughts. And we have done more than 30 webinars in the last 6 months. And this webinar is jointly organized, the museum is jointly organized by Kerala Social Security Mission, and our Executive Director, Dr. Mohammed Ashil is there. And we have an eminent panelist, starting from Dr. Maharudra from Mumbai, Dr. Santosh Kumar, Dr. Fathahudeen, Dr. Aravind, Dr. Bipin Gopal, and Dr. Kavitha. And later, Dr. Ravi will join in the concluding part. And we'll start the proceedings with, I'm Dr. Sajeesh. I am the moderator. I am the trustee of Amuseum ArtScience. Panelists will present, the program detail is that each panelist will present around 9 minutes for each presentation. We have 6 presentations. We'll finish in 1 hour, and after that we have a sharing of thoughts by some of the healthcare workers deeply involved in COVID management. And after that we have a Q&A session. And the Q&A session, we have a broad area of public participation is there, starting from the healthcare workers, media persons, doctors, paramedicals, and all. We expect a very healthy, productive webinar here. I don't take much of time, and I am inviting the first speaker, Dr. Aravind R. Before that, our telecast is on Zoom webinar platform, and in Facebook Live is active. And later, we will, in 1 or 2 days, we will full video we will telecast in our YouTube channel. All our Amuseum ArtScience. Visit our channel and Facebook. And over to Dr. Aravind R. And he is the head of the Department of Infectious Disease, ID consultant to Sri Chitra Medical College and Science, Technology and Medical Science Institute, and RCC, Regional Cancer Center, and a member of State Medical Board. And that the name of Dr. Aravind is familiar to all the doctors who are working in the COVID scenario. That is the key person in medical college, in COVID management, formulating the guidelines and protocols and all. I'm not taking much of time. I'm straight into the topic. Over to Dr. Aravind.
Thank you, Team Amuseum, for this opportunity. So I will be talking on the post-COVID-19 clinical syndromes, as we have discussed initially. So following all the major viral illnesses, like say measles or even complicated dengue fevers or Epstein-Barr virus infection and all, sometimes the patients may take around say weeks to months to recover. So that is what we refer to as the post-viral syndromes. So after COVID-19 also we are observing this entity, and that has been termed as a long COVID syndrome. Multiple terms have been used, and commonly the accepted term is the post-COVID-19, the clinical syndromes. And I will be taking you through the entire gamut of the manifestations which we are observing in patients who are recovered from, so-called recovery from this COVID-19. And we are concerned about COVID-19 because of the magnitude of the number of people who have been infected with COVID-19. Even if we say that around say 2% of the people are going to have only this post-COVID-19 syndrome, the 2% of say 5 lakh in Kerala will be a big number. So we are concerned about the morbidity associated with this post-COVID-19. To take you through the what exactly is this long COVID or post-acute COVID-19, it is a multi-system disease, sometimes occurring even after a relatively mild acute illness. The patient need not be really sick to experience this post-COVID syndrome. Even it has been observed in so-called asymptomatic or those with mild symptoms, even though the incidence in such cases is pretty low. So post-acute COVID-19 is defined as manifestations extending beyond 21 days from the first onset of symptoms. This is the post-acute COVID-19. So around 10% of the patients do experience this post-acute COVID-19. And chronic COVID-19, if the symptoms are persisting for more than 3 months from the onset of symptoms, that is in around 2%. So we have many other studies saying that around 75% of the patients are having this issue. That actually depends on the inclusion criteria of the study. If the study is done only on those who have been in the ICU, then it will be around say 80 to 100%. So if you take all the patients, the asymptomatic, the mildly symptomatic, the severe, etc., probably around 2% will develop this chronic COVID syndrome, and around 10% will experience this acute COVID-19 syndrome. Now we need to know why this is occurring, why some patients are developing this post-COVID-19 syndrome. Obviously, those patients who are sick, that is our category C patients who are in the ICU, etc., will take around 3 to 6 weeks to get back to their normal activity. The other features are the elderly, those with comorbidities are likely to have lingering symptoms which may persist for a long period of time. Interestingly, the females, we know the males are having the severe disease and the mortality is higher in males, but females are the ones who are likely to develop this post-COVID syndrome. And then why this is occurring? It is supposed to be because of the persisting inflammatory response, the cytokine storm, and also there is a dysregulated inflammatory response, and this dysregulated inflammatory response can persist in different organ systems for weeks to months, and that is the reason why some patients are experiencing this post-COVID syndrome. It will be better to keep this picture in mind. So all the manifestations in COVID-19 is related to the entry of the spike protein or the SARS-CoV-2 virus into the different organ systems. Wherever this ACE2 receptor is present, they are likely to have manifestations pertaining to that system. So these manifestations can occur during the acute phase of the illness and also can occur during the convalescent period. So if it is occurring during the convalescent period, we term it as the post-COVID syndromes. You can see that none of the systems are spared. The patients can have these thromboembolic manifestations in the convalescent period. Patient can have these cardiac manifestations in the convalescent period. Patient can have this dysglycemia persisting throughout this convalescent period. Patient can have an entire gamut of manifestations in the neuropsychiatric axis. Patient can have renal failure, etc., which can progress through the convalescent period. So wherever this ACE2 receptor is present, the patients are likely to develop symptoms during the acute phase, and the patients are also likely to persist with these symptoms during the post-COVID phase as well. Now this is the initial study, just a multi-state phone study from USA. It is a telephone-based study which looked at the presentation of this post-COVID syndrome. So it was fatigability followed by cough, congestion or shortness of breath, the loss of taste or smell. That is, basically these are observed during the acute phase. In some patients, it can persist more than 21 days. Then the headache, body aches, diarrhea, nausea, chest or abdominal pain, confusion. Basically, the thing is that majority of the symptoms are so non-specific. So in this array of symptoms, we should be focusing on the alarm signs or symptoms so that we can handpick patients to attend to our post-COVID clinics. Interestingly, this is another study which showed that there is impairment of concentration around 28%. So this is very, very important. We can expect this, the myalgias, the arthralgias, etc., persisting for weeks to months after a viral fever. But what about this impairment of concentration observed in 30%? Problems with the sleep, getting good quality of sleep in seen around 30%. The memory loss, the acute memory loss in around 34%. All these things are reversible, but then the torment that the patients, the so-called recovered patients have to go through because of this memory loss, the disturbance in their sleep, the impairment in their concentration is actually huge. Then dyspnea, I am not going to talk about dyspnea. So exertional dyspnea is the red flag sign that we have to be focusing on. Fathahudeen sir will take you through a detailed lecture on that. And fatigability is observed in around 55%. This data from the West. Now, this is the data from our own institution, just done in the healthcare workers. You can see that around 60% of the healthcare workers recovered from COVID-19 had this excessive fatigability. Exertional dyspnea in around 30%, alteration sleep rhythm in around 24%, excessive hair loss in 20%, muscle pain in 15%, headache in 15%, polyarthralgia in 10%, and this brain fogging. Brain fogging means that you cannot organize your thoughts. So like what you used to do prior to the occurrence of this COVID-19. So in order to get back to your normal routine work frame, it may take around weeks to months. That is what is referred to as cognitive blunting or this brain fogging, and anxiety as well as depression, which are expected. So basically, COVID-19 does not spare any system. So during the post-COVID syndrome also, the patient can present you with cardiac problem. That is, if you're having palpitation, could be due to myocarditis, cardiomyopathy, etc. So if you're having exertional dyspnea, if the respiratory system is involved, it could be lung fibrosis, pulmonary artery hypertension, or embolism. And it can affect the nervous system also, because ACE2 receptor is present in the blood-brain barrier, and the cytokines can actually leak into the brain parenchyma because of endotheliitis, and can lead to the persistence of anosmia, the stroke syndromes. The patient can present with stroke syndromes even after recovery. Patient can present you with myocardial infarction or mesenteric ischemia because of ongoing thromboinflammation after recovery. Patient can have the short-term memory loss, reduced attention span, confusion, poor quality of sleep, cognitive impairment, cognitive blunting, etc. And the mental health issues, recently there was a Lancet article saying that around 20% of those who are recovered do have some sort of serious neuropsychiatric issues like anxiety, depression, and sleep disturbances. Musculoskeletal, we have also already discussed, of which the most important happens to be this excessive fatigability, which can progress to this chronic fatigue syndrome. Excessive fatigability is fatigability due to following all the physical exertion, mental exertion, or emotional exertion, which is actually not relieved by rest. Basically, the UK NIHR has grouped all these symptoms into 4 clinical syndromes. One is the classical critical illness syndrome. There's anyone who has been in the ICU may take around weeks to months to recover. That's true with COVID-19 as well. The post-viral fatigue syndrome, in case after 6 months, some of them can progress to this chronic fatigue syndrome. Lasting organ damage. Fathahudeen sir will talk in detail about the lasting organ damage, especially if it happens to the lung and the fibrosis and all. And most interesting aspect is this fluctuating symptoms with slow recovery. This after recovery, some patients say that I have headache today, and after say 2 days, you will say polyarthralgia. So fluctuating symptoms which go on for weeks and months, and so incapacitating to the healthcare workers and other patients, and we need to pay attention to this as well. So we don't have enough data on what is going to be the long-term outcome of this post-COVID syndrome, because we have familiar with this virus only for the last 8 months. But if we look at what happened with SARS in 2003, we can see that this chronic fatigability did persist in around 20% of individuals even after 2 years, and exertional fatigability, exertional dyspnea actually did persist for in around 5%. It took around 15 years for their lung function to become normal. So probably we have a study from Hong Kong in healthcare workers. So this showed that majority of them had to drop out of this problem because of excessive fatigability, which persisted for around 4 to 5 years. And then heart is also not bad. The exertional dyspnea, if you rule out a lung pathology, we need to look at the heart to see whether there is the myocarditis or a cardiomyopathy or a systolic or a diastolic dysfunction also. And this is how we have organized the structure of the post-COVID clinics, about which the Bipin sir will be speaking in detail. So we cannot afford to have all the patients who are recovered from COVID or in the convalescent phase crowding our post-COVID clinics, which have been set up in our FHC, PHC, and CHCs. So we want to handpick patients with red flag signs like dyspnea, palpitation, chest pain, unilateral pedal edema, or syncope. Basically, we need to handpick patients with a serious pulmonary issue or a cardiovascular issue, or a DVT, so a pulmonary embolism like that, and we would like them to come to the first line clinics, and from there a telemedicine consult will be obtained. If the patient requests a PFT or say HRCT and things like that, they will be referred to the second tier as well as the third tier, the post-COVID clinics in the district hospital as well as the medical colleges. So thank you very much. So the post-COVID clinical syndromes actually may not lead to mortality, but then the morbidity associated with it is actually real, and we need to tackle it in a very serious fashion. Thank you very much.
Thank you, Aravind, for we can't expect this much authority speech on post-COVID syndrome in 8 to 10 minutes. Excellent, Aravind. Thank you. And we will move on to Dr. Fathahudeen for what Aravind left, and the main system. We know all the respiratory system, and he is the expert in that system because he is vice principal in Govt Medical College Ernakulam and head of the Department of Critical Care Medicine, Pulmonology and Critical Care Medicine, and active COVID physician. I can say that because he has seen all the cases of COVID. And over to you, sir.
Thank you, Dr. Sajeesh, for your kind words. Thank you, the museum organizers, President, Secretary, for having given me an opportunity to speak. I think Dr. Aravind has removed his share screen. Then only I can share the screen. So I'll try to share the screen now. Let me see if I can. So you have listened to Dr. Aravind about the post-COVID syndrome in detail. So basically, when we refer to a clinical condition and syndrome, you should have a constellation of symptoms, which usually lasts for a long period of time. But this COVID, the post-COVID syndrome, to me, at least at the lung level, is basically a misnomer. It has to be ideally called as a long COVID disease. Because as you all know, when an infection occurs, your test could become negative any day between 3 days to 10 days. So the test negativity is being seen by the people, the common man, as that they have been cured of COVID. This is the basic problem. It is not. So what actually does your virus actually do to your body? The virus just causes an injury through immune mechanisms and it disappears. This is what is called the hit and run. That's why for some people, the virus remains for 10 to 14 days. For some people, the virus disappears soon. So what determines the outcome on severity of a disease in a given individual is the interaction between your defense system, what is called the immune system, and the virus. If your immune system overtly react, then you are going to have a lot of organ damage. What is it that determines this organ damage is really unknown. Why when 10 people get or 100 people get virus, why only 5 to 10% will get this disease very severe, and why around 5% or less than 5% will die? We don't know, probably genetically mediated. We need more data on that. So the point I want to drive, number one, is that it is a long COVID. It is not a syndrome. It is not post also. Post is basically based on the test. If you do an antigen test, it will show an earlier clearance than your RT-PCR. So your patient is told that you are cured of COVID. But on the 10th day, you discharge him. He will go home. But remember, it is by around 8th and 12th day, the respiratory system get actually involved at the organ level. So the patient may develop a patch of pneumonia by the time his antigen is negative. And they start desaturating, but they are told that they are negative. This is the issue. So the message that I want to drive home is that it is actually a long COVID. Just because your COVID test is negative doesn't mean that you are free from COVID active disease. I told you what actually happened. So that is number one. Number two, what is actually happening in your body when the virus hit? There is absolutely two important things. It causes clotting of the entire microvasculature in your body, particularly at your lung level, at your heart level, at your kidney level, at your central nervous system, brain level. The maximum brand of attack occurs usually in the lung, because that is where your virus actually dwells, because the ACE2 receptors are abundant in the lung, in the type 2 alveolar pneumocytes, as well as nervous system and your heart, as well as your kidney. The most important thing is that these ACE2 receptors are abundant in the vasculature inside the blood vessel. So the virus actually causes a kind of swelling and inflammation of your all blood vessels, resulting in what is called endothelitis and clotting inside the blood vessel. So these are the two things. Once this happens, then the end organ damage occurs. If it occurs at the lung level massively, you see that your oxygen level falls, which can occur well after your COVID test becomes negative. During the acute phase, which is between the 7 days to 21 days, most of these patients either recover or they go to the ICU. They go to the ventilator assistance. Many will recover, many will die. So beyond these 3 weeks, the pathophysiology which I have told you, the clotting inside the blood vessels, as well as, since I told you the virus has actually hit and run, resulting in a release of large number of chemical mediators, what we call cytokine inflammatory mediators, which actually causes continuous inflammation in multiple systems, at the lung level, at the heart level, at the CNS level. So depending upon the cytokine storm which has hit maximum, the patient will have symptoms referable to that organ. So I have told you the lung is the most important system which got affected. So what happens? They usually will have a patch of pneumonia by the time their RT-PCR or antigen test is negative. But since the antigen test is negative, usually they will be asked to go home. And what happens? The lesion progresses. The hypoxia, the fall of oxygen level continues. They usually complain of dyspnea at rest or on exertion. Exertional dyspnea usually occurs when they do small household things like lifting a chair or straining at stools or just going upstairs. So this mild exertion produces a profound panicky reaction kind of exertional breathlessness, which is highly alarming for the patient. They will be brought to another hospital where the doctors tell him that you have COVID. Now the patient would say, no, I have been treated in another hospital where I was told that my COVID test is negative. Then what is this? No, the doctors are actually nowadays, we are finding it extremely difficult to convince the patient that your COVID test may be negative, but your disease is still active and lingering, which is the reason for progression. Right now, I have a patient who has been having respiratory symptoms, desaturation for 40 days. And on 40th day, he has gone on to ventilator. It cannot be post-COVID. So there are situations where a patient, the percentage of patients who goes to this level is less. That is one relieving thing. That only less than 3% of the patients with lung involvement go for the protracted COVID lung lesions persisting beyond 3 weeks, 4 weeks, and going for irreversible hypoxia, which requires mechanical ventilation. Once they reach at that level, then I don't think any force on earth can reverse the process. This is because there is extensive clotting at the microvasculature. That is important. If you take a big scan with a contrast, you won't see major blood clot as you see in pulmonary embolism. You would see distal peripheral complete blockade of pulmonary microvasculature, resulting in diffusion defect, what is called ventilation perfusion mismatch, and hypoxia. This hypoxia is persistent and progressive, where no steroid can work, where the ventilator cannot work, because what does the ventilator do at that point? The ventilator is only trying to drive more positive pressure and more oxygen with the hope that the diffusion will improve. The diffusion will not improve because the filter of the lung, what is called the alveolar capillary membrane, is completely blocked by the microclots. These microclots actually occurs over a period of time, starting from within a first week of onset of infection, maybe going on a continuous for 2 to 3, 4 weeks. So this is the reason for this long COVID presenting with exertional dyspnea, significant hypoxia, and there are reports of patients developing pulmonary hypertension. That is again the same mechanism. The pulmonary vasculature is completely blocked, producing increased pulmonary vascular resistance and pulmonary hypertension. Probably we are going to see, as Dr. Aravind was showing in his slide, we are going to see more protracted things beyond 6 months, beyond 12 months at the lung level. So we are looking at those patients who had actually had moderate to severe COVID pneumonia and ARDS. They have recovered thankfully, but what will happen to them? Now, the another most important doubt which I want to clear is about the lung fibrosis. Nothing to worry. Fibrosis will take longer time. It is not as ominous as you would think. Fibrosis term itself is a little, not fitting in the context, because fibrosis is a chronic process which takes at least 3 months. Here, it is not actually the fibrosis which causes the desaturations. It is actually the microvascular trauma which is present, plus the onslaught of cytokine soup, cytokine inflammation, primarily by IR2 and IL-6, which is ongoing. That is the reason why you get persistent inflammation occurring in multiple systems. If it is at the lung level, they present with hypoxia, exertional dyspnea, and some of them, at least 2 to 3% of them will go, just as I have shown your case report, where on the 40th day, his COVID test became negative way before. Within the 10th day, his COVID test became negative. but he continues to be oxygen dependent. He was on a non-invasive ventilation, then had gone on to ventilator. At that point of time, all the parameters have come down, but irreversible organ damage had occurred at the lung. This is actually not fibrosis. Nobody has done a biopsy into the lung to say that this is fibrosis. So it is basically a continuation of the active pathological process long after the virus has been cleared from your body. So it's actually a long COVID disease. Now, should you really worry? This is for the people other than doctors. Should you really worry about this lung syndrome? No, not at all. It is not at all very, very common. Only less than 3% of the people who actually had significant moderate to severe ARDS and pneumonia who recovers develop this. And who are the ones who develop this? There are 5 risk factors. 1, smokers. 2nd, chronic alcoholics. 3rd, patients with morbid obesity. And for those who are having pre-existing lung disease like COPD, asthma, or they had tuberculosis in the past. And the 5th one is those who have been exposed to a high degree of air pollution. So air pollution is a most important determinant, especially in metros, where you see a large number of patients coming with post-COVID pulmonary symptoms. Actually, the active COVID symptoms like exertional dyspnea, desaturations, even requiring oxygen. So if you see a patient at the end of 2 weeks or 3 weeks with these symptoms, what will you do? Most of the time, these patients usually have had a CT. The CT would tell you, the CT chest will tell you what is going on. Many a time, it will not be the classical fibrosis that you have seen in other lung diseases like hypersensitivity pneumonitis or idiopathic pulmonary fibrosis. No, it is not that. It shows ground glassing, shows some amount of diffuse reticulations, and most of the time, the consolidation like patches will be seen. It is not the classical fibrosis. So the term lung fibrosis, when we use one, should be very careful. I totally disagree with the term lung fibrosis because it's an active COVID disease, which is with the persistent 2 important things. One is cytokine-mediated vasculopathy and cytokine-mediated inflammation and intravascular coagulation. So in such group of patients, you have to definitely escalate treatment with high dose steroids. I usually give 32 milligram of methylprednisolone for another 3 to 4 weeks. That is very, very important. No need to abruptly stop it. I'm not talking about the active steroid indication as in recovery trial, where the patient in the ICU or in the ward with B+ or C1 or C2 symptoms receive dexamethasone or equivalent steroids for 10 days. I'm not talking about that. I'm talking about this minority of patients who continue to be having exertional dyspnea. They have to be treated by 2 important medications. Number 1, steroid to suppress the ongoing inflammation. You have to at least give him 32 milligram of methylprednisolone for 3 to 4 weeks and then taper. There is no point in giving it for 1 more week and stopping. No. Plus, you have to always add an oral anticoagulant like apixaban. I usually give apixaban 5 milligram twice a day for 2 weeks. This is very important. And one important observation that we have made is that whoever who actually had a significant ARDS or COVID pneumonia in the ICU, who received therapeutic dose of heparin, while on discharge should mandatorily receive 5 milligram of apixaban twice a day for 2 weeks, which would to a great extent actually prevent the development of exertional desaturations, exertional dyspnea. Now, other symptoms like cough, breathlessness, fatigue, all has been described by Dr. Aravind. So my take-home message to wind up is that there's nothing to worry about the so-called active post-COVID scenario. Post-COVID lung disease is a continuation of the pneumonia that you had. Just like any other pneumonia, this also takes time to resolve, take 6 to 8 weeks time. And those high-risk group patients who received therapeutic dose of heparin in the ICU, while on discharge, should mandatorily receive an oral anticoagulant like common man's term blood thinners, like apixaban 5 milligram twice a day for 2 weeks. Some patients may even require more, but we don't have a recommendation beyond that point. There is no harm in giving it. If you see a patient developing a DVT, I have seen patients developing DVT in the immediate 2nd or 3rd week of COVID.
Yeah,
COVID
sorry to
scenario.
interrupt. Yeah, shall we?
So with that, I conclude my talk. Thank you, Dr. Sajeesh.
Okay. Thank you. It's a very promising thing that the fibrosis is actually a misnomer, and that too in a very less than 3%, and we have something to offer also. As a great message. And we want to, the fibrosis is thrombosis is the main culprit. Wherever the blood vessel is there we can have the thrombosis. All age groups. But in active COVID, the children are spared in a great extent. But what happens to the post-COVID things? Are our children safe or not? Over to Santosh sir. Sir, please. Santosh sir is the head of the Department of Pediatrics, Government College, SAT, Thiruvananthapuram. Over to you, sir. It may be just add one thing that our discussion part, we expect an active discussion, and all of the presentations are in English, even though in our Q&A sessions and all the participants can ask in either in English or Malayalam. We can communicate in answer the questions in either in Malayalam or English. Not an issue. Malayalam തന്നെ ചോദ്യം ചോദിക്കാം, മലയാളത്തിൽ തന്നെ ഉത്തരങ്ങളും പറയുന്നതായിരിക്കും. Over to you, sir.
Good evening. Thank you for the invite and thank you for the nice words of introduction. What I will be discussing is what is our experience with dealing with children who has had COVID. We have had about 520 children in the past few months. Basically, understanding the disease is still evolving, more so in children, because the number of children affected is much less as compared to adults. So the data and understanding the disease as far as a child is concerned is less well evolved compared to that adult. The percentage may be something like 1% of the total COVID symptomatics. The children will be something like 1%. So it's not a big chunk in any way. And death is extremely unlikely. And the deaths that we have had actually were not related to COVID. We have had deaths, but our analysis is it is possibly not related to COVID. Now, what is about children having post-COVID issues? As Dr. Aravind mentioned about the fatigue, lack of sleep, and so on. In children, it's very difficult to actually make out because children are always active. Even if they have mild fatigue, they simply go around and play. So it's very difficult to make out. And regarding the anxiety and worry regarding this disease, again, very difficult to make out because once the schools are closed, now children are actually in a different state of mind, and that cannot be equated to post-COVID scenario. Now, the real dangerous thing post-COVID as far as child is concerned is hyperinflammatory syndrome, what we call as MIS-C, where it's first of all, I must say it's a very rare condition. So we should not actually get frightened about all these clinical manifestations. It is not an immediate post-COVID thing. It takes about 2 weeks, maybe 3 weeks, maybe 4 weeks. So within a month, you develop bizarre symptoms. Bizarre means symptoms that are not really related to COVID. Which the COVID symptoms like your sore throat, those things are not there. But then what do they come with? They come with, curiously, abdominal pain. Abdominal pain, we have found it as very common. Second would be fever, persisting fever. That is actually, fever is the first thing and abdominal pain is the second commonest thing. Then they do have vomiting and rash. Over the skin, they have reddish patches. Because non-doctors are there, I'm using these terms. And your eyes may become red. and you may feel like fainting. That is basically because of the circulatory shock. And another common thing is swollen hands and feet. That is what we described as edema. So these things, when you get after a COVID episode, we suspect it could be this. Then you may be wondering whether it is a peculiar phenomenon after COVID. Actually, no. We have had a closely related or almost same disease called Kawasaki disease that we have been having for years together now. And we do not know what is triggering that Kawasaki disease. And the so-called MIS-C that we describe after COVID is almost same or a cousin of this Kawasaki. So that means the same thing, the virus insult and the body reacting to that in a peculiar way that has been going on there. But now that we have a pandemic of COVID, all these things are following COVID. So after a viral insult, some children are reacting in a bizarre way. And that is what is the reason for Kawasaki disease. And this MIS-C that we describe is very similar to Kawasaki disease. Possibly the only difference is we get it in bigger children also. Like in Kawasaki disease, we really expect below 5 years. Here, above 5-year children are commonly affected. So that is the only major difference that we have. And many organs are affected, and the organ that we are afraid of is heart. And what happens to the heart? Two things happen. One, your heart muscles get inflamed. That means it gets swollen up. And second thing, the blood vessels that is supplying your heart, that develops balloon-like swellings. And you know what happens if balloon is inflated beyond a limit? It just bursts. So that is another frightening thing. These two frightening things happen in the heart. And if the heart is inflamed, that is swollen, that means it cannot pump with the same strength as it was doing before. So what happens? Less and less of blood reaches the areas where it matters. Suppose less blood reaches the kidney, then what happens? It can filter much less blood. And so the urine that is formed is much less. So you tend to say there is a kidney failure because the kidney is failing to remove whatever waste product that is there in the body. Unless it is filtering and the water is coming out of kidney, it cannot really bring the waste product along with the water. So you have different organ dysfunctions, of which heart is the most frightening area. For example, the heart is contracting or pumping in a much lazy way. What happens? The blood inside the heart tend to remain there, and any blood remaining anywhere will clot. That we all know, no? So there is a chance of blood clotting in the heart itself or in the ballooned out blood vessels. So that is the danger of having all these aneurysms, and you can have thrombosis in various areas. And if the heart is pumping very sluggishly, enough blood is not reaching where it should. And that is what is going to cause shock. Shock means enough blood is not reaching the areas where it should. So the organ dysfunction sets in. That means the liver may not be acting as normal because the blood is not circulating enough to liver. Similarly, different organs gets affected, and the skin you get the rash. That is also actually a vasculitis. So vessels become dilated and produce the reddish color. So now, when should you really suspect that you have this issue? One, you have suffered COVID in the past 1 month or so. And it need not be that you have had a symptomatic COVID. You can be totally asymptomatic and still you can have it. And even in the history, if you think that the child has had contact with a COVID patient, that is enough to suspect this, because this is something that is not expected in a normal scenario. So I was just starting to tell about the symptoms they come with. One was the fever. The second one I said, what we have seen is abdominal pain that is much more common than what is described in literature that we have seen. And then diarrhea. Diarrhea is quite common. Diarrhea in acute stage is also common, but in this post-COVID also we have seen diarrhea. And the conjunctival congestion, that is something that we see so very often in Kawasaki disease, non-purulent bulbar conjunctivitis. That also we are seeing here. But what we are seeing in Kawasaki, but not seeing so very commonly in MIS-C is lymphadenopathy. That is slightly less common. But shock is actually more common here as compared to the Kawasaki disease as far as our experience goes. Our experience means we have had 17 MIS cases so far, and almost 25% of them have had coronary dilatation. So when you have a coronary dilatation, or when your heart is pumping very, very sluggishly, so much so you think the blood inside may clot and cause obstructions, that is the trigger for us to use the anticoagulants. Normally we use aspirin. Normally we use aspirin for all Kawasaki disease and MIS. But going to anticoagulant, our trigger is either finding aneurysms that are big enough and very sluggish, or ejection, what we technically call a low ejection fraction. That those children we use anticoagulants. Now the treatment, since it is a mixed audience, I will not go in detail to treatment part of it, but basically we find methyl prednisolone to be far superior to IVIG, although in Kawasaki we see it other way around. So we tend to use this thing, but where we suppose it is not responding to methyl pred, we generally go on to have a trial of IVIG. But IVIG as a first drug of choice, we take it when the child is small, like less than 5 years, where it's more like we manage it more like a Kawasaki disease. A combination also we do give occasionally, but generally this is the way that we do. Aspirin is universal. All of them will receive aspirin. Suppose the liver function is very deranged, then possibly we will hold on aspirin for a few days. But otherwise, we bank on aspirin much more than the anticoagulant as far as the child is concerned. I think I'll not go deep into the management part. Any questions you can take up during interaction? Thank you.
Thank you for the nice presentation. Actually, even though I was talking about the pediatrics and all, he covered all the systems also. Because in a, we very difficult to in a small webinar, one of our sessions, we in all system actually we have to cover the cardiovascular system, other psychiatric issues. So many issues are there, but in the broader aspects, you are doing a great job by helping us in by covering all the systems. Fathahudeen has brilliantly covered the respiratory and you done all. Thank you, sir. Over to Dr. Maharudra Kumbhar, and he is officer on special duty from Mumbai. Actually, he is our guest from Mumbai. He is our special officer on duty in Sevenhills. I have been with him for 2 months there in Mumbai. And the volume they handle is that they have a Sevenhills hospital with 1,500 bed dedicated hospital with ICU strength of 250 ICU strength COVID hospital, COVID ICU beds. And out of the 250, now we are still yesterday is around 200 are fully emptied and only 50 are. And the peak time they are fully occupied actually. And over to Maharudra, we are eager to hear your experiences on. Actually, they have started the post-COVID clinics and all the post-COVID issues have come there and they are managing it. Over to you, my dear friend.
Yes. Thank you, everybody. Myself, Dr. Maharudra Kumbhar. I am here, officer on special duty, posted in the Sevenhills Hospital. Sevenhills Hospital story is known to all India because it is a unique hospital, first in India who gone in insolvency. So hospital is planned and designed in 2005. Construction started in 2005 to completed in 2010, and they have started operation in 2010. They are running only 300 beds for the 3 to 4 years, but then after due to the insolvency and other issues, hospital is not functional. So in the March, when the first case in Mumbai detected on 7th March, 9th March, Honorable Municipal Commissioner decided to use this hospital initially for quarantine because it was closed since last 2 years. So it is very difficult to start as an hospital, though it is planned as an hospital. But very less facilities are available at that time. But in the peak time, only 45 to 50 days, we make it fully functional multi-speciality hospital. The beauty of the hospital is unique infrastructure. When I say infrastructure, why? There is cross-ventilated beds, negative pressure ICU cubicles with a 140 square feet of space is dedicated to one bed, like NABL standard. So it was designed per se, which is a pandemic compliant health infrastructure. I am speaking something different upon the post-COVID, but just for the introductory space, I'm giving you just a background of the hospital. So in that scenario, we have started these services, and I want to thank Municipal Commissioner, all municipal authorities, Government of Maharashtra, and team of Kerala. Through the Mission Mumbai, they visited, they personally experienced first-hand experience in the working in the COVID negative pressure ICU, and they have seen the patients also. That was too early stage where health workers, doctors, nurses are so afraid of to work in the COVID environment. So that time, Team Kerala came, visited and worked and set the pattern of the certain treatment. We have evaluated so many cases, and then the journey started about the thinking about the reducing the mortality rate. And yes, thanks to our government who has taken an initiative to establish this is one of the largest hospital, not a transit or anything. This is a multi-speciality hospital dedicated to the COVID pandemic only. So thanks Mission Kerala, Dr. Sajeesh, Dr. Santosh, and everybody from the Kerala who has came here and who has wished to came here, work here. First of all, I want to thank you everybody, and I want to thank you everybody for inviting me as a panelist for this post-COVID discussion and webinar. So thank you everybody. Yes, we have started post-COVID OPD. We have faced same problem, whatever Dr. Aravind and Dr. Fathahudeen sir had said so. I think Dr. Fathahudeen sir is a respiratory physician and he works more in the ICU. But sir, what Dr. Aravind sir says, that also making the sense, because in our post-COVID OPD, till the time on telephonic conversation, we have screened about more than 3,000 to 4,000 patients. Till date, we have discharged more than 15,000 patients. Out of that, 3,000 to 4,000 symptomatic patients we have screened in post-COVID OPD through teleconversation. And out of these 3,000 to 4,000 patients, 1,000 plus patients visited in our post-COVID OPD. Out of the 1,000 plus patients who visited with post-COVID OPD, all the symptoms regarding what Dr. Aravind sir has said has been seen in that patients. So more specifically, lung, heart, kidney, brain, and in brain, there are two parts of the brain. That is, one is a pathological, and another one part we neglect always in the medical science, even in the psychiatry part also, we more concentrate on the pathology of the disease rather than the psychology and physiology of the disease. Total psychological and physiological disturbances in the brain. So when I'm saying the brain, there are two parts. One is the pathological. There are n number of incidences we have seen in they came up with lacuna type of infarct cases, TIA type of symptoms, cerebrovascular accident also we have reported. These type of patients also came in the neurological cases. And third part is intestinal one, that is where vitamin B12 deficiency is persistent is there. In the whatever you call it, as a long COVID or post-COVID, but vitamin B12 deficiency, disturbances in the diet cycles and all these things, symptoms are persisting. Here I want to make one point, though we all are clinicians, what is exactly COVID pandemic is? As sir said, hit and run case. Is it an event? Is it an accident, or is it a process? So here, just going one step ahead, what we are right now debating is COVID, post-COVID, long COVID, but I'm thinking about something on different part, that is what after COVID. Because virus triggering the all type of comorbidities into a complicated like scenario. Diabetic patient become more complicated. Chronic kidney disease patient become more complicated. And incidences of acute kidney disease is also reported in the COVID, after COVID. Those who don't have any type of comorbidity, but just because of they got the infection of the COVID. And now, recently our KEM hospital has also published the paper out of the Sevenhills data, where we have we have published the study that out of 116 patients, near about 46 patients are newly diagnosed acute kidney injury who are requiring the dialysis on long-term basis. So COVID is not an event, COVID not an accident. It is a process per se, and it will remain long for challenging to us, because at the same time, one thing we are missing, sir, we are giving steroid, we are giving heparin, we are giving remdesivir, we are giving tocilizumab, but we don't know what remdesivir is affecting on the patient. Are these symptoms only related to COVID, or are these symptoms we are prescribing in this pandemic to the patients without studying their pharmacovigilance, pharmacokinetic and pharmacodynamic properties? Because we have used more than 10,000 plus remdesivir, and we have large number, but yes, studies are very few who can suggest us that yes, it is a very safe drug, or it doesn't have any complications. So what I have suggested to my clinicians in nephrology also, that don't afraid of giving remdesivir to the patient whose GFR is even less than 30, because less than 30, GFR is 30 is universal precaution to any type of drug. But when we are giving that remdesivir to such a patient, we are getting very positive result in the ICU. Such patients are recovering very fast. Their oxygen requirement is going down. So we are giving remdesivir in that patients also, and remdesivir is giving very good result to us. Second point I want to say is that in the injection tocilizumab, most of the study are conducted, even in the USA and Europe, studies are conducted on critically ill patient. But use of tocilizumab is such a like a magic to the patient when you are giving remdesivir, or you have used the flavipiravir. Patient is persistently requiring the oxygen, his saturation is maintaining about 93-94% on 10 liter or 15 liter, and not improving beyond that. On third dose of remdesivir, if oxygen requirement is not going down, at that time, if we give injection tocilizumab, then suddenly in next 2 to 3 days, his oxygen requirement will come down. He will wean off of the oxygen. He is happy, and I have near about 100 plus such patients comparative to establish a comparative study that tocilizumab given in the critical patient doesn't have much survival rate, but tocilizumab given early as possible, when there is a right time to give that, you will get a very positive result, which help us to reduce the mortality in Sevenhills Hospital. Another one thing I have established even in the Maharashtra, and I have circulated with Sajeesh sir also, 5E, strategy of 5E, early diagnosis, early investigations, early interventions, early ICU care, and early detection of complications. So these 5E strategy we have established. Now coming to the point, how this, all my discussions coming to this post-COVID syndrome and all these things. As I say, it is a process. When we say it is a process, it is a long run process. So post-COVID, long COVID, and after COVID, this COVID will remain for long, not only in India, but in the world. because nobody knows virus changes itself or not. Genetics of virus we don't know. Where today we have identified that it is attaching to the AC inhibitor, but symptoms itself suggesting that yes, multi-organ system involvement is there. So there may be other factors which are getting triggered due to the infection of the COVID. So on that perspective also we have to think out. Now sharing the experience of my post-COVID OPD, most of the symptoms has been covered, or most of the organs has been covered by the Dr. Aravind sir also, and most of the clinical things has been covered by the Dr. Fathahudeen sir also. Here I want to say vaccines, I'm not going to comment on that, but yes, health infrastructure and preparing our health worker is essential things for not only for the post-COVID, but after COVID and beyond that also. Because now new diabetic mellitus cases, those who don't have diabetes previously also, now their HbA1c is on higher side. They are newly arrived diabetic cases. So even if we consider 2% of population, and if we consider 50% of Indian population will get affected by the COVID pandemic also, or forget about the 50%, but even if the 10%, right now 10% population is affected, out of the 10% population, if we consider, then also this figure will go very high. And we have to prepare our health worker for incoming storms, even post-COVID or after the COVID stage. So kidney diseases, diabetes mellitus, interstitial lung disease and bronchiectasis incidences. Though I agree with Fathahudeen sir, it is not a fibrosis per se, lung fibrosis per se. But yes, interstitial lung disease, very neglected phenomena. Most of the medical students forget to learn about the interstitial lung disease because it is really a phenomenon, and even medications are not available for that. So giving the steroid also help to the interstitial lung disease, so we are giving the steroids. But such type of challenges are coming. At the same time, I want to identify beta cell destructions very commonly occur in the COVID patient. Their HbA1c levels. In what happened in the health worker, they are saying that doctors or clinicians while treating the patients, when the relative are asking, even in the post-COVID OPD, that why the sugar is still high. We simply say that corona affect these things. So due to the steroid effect, for a certain time you will have the high sugar. No, we have correlated these findings with HbA1c. They're persistent. Now we are in the near about 8 months, and HbA1c figure is for 3 months validated from the 3 months. So now persistently their HbA1c last 2 months is more than 7. So they came before, they are non-diabetic. Now they are either pre-diabetic stage or diabetic stage. Same thing is with the kidney. Same thing with the myalgia. Yes, myalgia, there is muscle weakness and continuous muscle weakness. Even after 3 to 4 months, patients are complaining that they're unable to walk for 5 kilometers. Previously, they used to walk for the jogging or walking or evening walk, morning walk. They used to walk for long, but now they are feeling this weakness, myalgia symptoms, and exertional dyspnea-like symptoms. These are the things. Second most important thing is effect on mental health. Post-COVID totally affected mental health of the whole population, not only the patient, but the family, as well as their culture is get disturbed. Pathological mourning. Yes, we have seen the patient. Husband is positive, wife is also positive. Husband, after becoming negative, he goes home happily, and their relative, wife is in ICU, and their relative refuse to come to accept the body. So such type of incidences we have seen in our hospital also, and there are a lot of psychological disturbances. More of a health, though they have recovered from COVID, they will recover from post-COVID stage also, but they will never recover from psychological trauma, depression, memory, as sir said, memory. There is, yes, confusion. There is no remembrance, no efficiency in work, because they are forgetting the things where of the office work. And yes, that stage we have to concentrate on the mental health aspect also for the post-COVID or after COVID stage. So we have to include the psychiatrist and psychologist or panelists to derive such type of things to address on. So these are few experiences. We are still in the COVID, though cases are coming down, but still we are preparing for the second wave to come, because after festival season and after reverse migration, when COVID came, most of the population gone to the Bihar, UP, or other states of India. Now they will, after festival stage, they will come back to Mumbai, and there will be the rise in the number of cases. But before rising in the number of cases, we have prepared our post-COVID OPD setup also, counseling section also, and other interventions also. And one thing, it is not related to post-COVID, but yes, I want to highlight is that in initial stages, most of our policymakers and our health workers also misunderstood that COVID is only a respiratory disease or medicine disease. No, COVID is a multi-system involved disease. So multi-speciality approach is required, not only for the COVID, but for the post-COVID also. That has been, I think Aravind sir has already described, that is multi-system involvement is there. And yes, it is not a only hit and run case, it will remain for long, to challenge our knowledges as well as our strategy to deal with. Thank you everybody giving me a chance to speak with all of you seniors, because I'm too young in front of you. But yes, my mind is trained to assimilate the things. So I'm very thankful to you to invite me in this panel discussions, and I got so much encouraged. I will implement whatever Aravind sir has shown, whatever Aravind sir has shown or discussed in their discussions. I will start implementing in my hospital also. And thank you everybody. Thank you, Sajeesh.
Thank you, my dear friend. You are, of course, yes, I know that we know that you are very junior, but as far as COVID is concerned, you are an emeritus professor. So you have the immense experience. You have shared your immense experience, and what the plan the Maharashtra government of Maharashtra is having, and all. We already know that it's not a sprint event. It's already a more than 1,500 run event. Who knows? It's a marathon. We don't know. But so far we have discussed about the Maharashtra planning and experience and action. What about our Kerala? Our planning is talking. In Dr. Bipin Gopal is talking about COVID implementation of post-COVID clinic in government sector. Dr. Bipin Gopal is a nodal officer. You say a public health issue, and a nodal officer is that, because he is a nodal officer to non-communicable diseases, he is a post-COVID clinic nodal officer, elderly palliative care, and so on. So, over to Bipin.
Thank you very much for this opportunity, and thank you for the previous speakers for enlightening and enriching our knowledge. And we have been hearing about the post-COVID symptoms from the last few speakers, and I will be speaking on how the Kerala Government Health Services Department translated that knowledge to action. So we have implemented the post-COVID clinics in the system with the name Revive. The name Revive is coined by none other than Dr. Ashil. Means reviving Kerala, or closing the loop of COVID management. So we have seen the catastrophe that is brought by the coronavirus, the COVID-19 pandemic, and how it affected human lives. And we are yet to know about the real picture of the pandemic. And at a time when we thought that we are getting back the things to normal, a new set of issues have arisen in the form of post-COVID issues. It can be a simple tiredness or a fatigue or an exertional dyspnea, or it can be a multi-organ damage issue. And like the previous speakers told, there are more new things to be understood, no more things to be known. And it is the choice, it is the prerogative of any sensitive government to act on a new issue. And Kerala government, the health service department has controlled or taken action for the management of COVID in a much dedicated fashion. And similarly, the action for the post-COVID clinics have also taken place very early, and the initial part was done by the principal secretary to government in the form of a guideline for the formation of the COVID-19 post-COVID clinics. And we have set up the post-COVID clinics not only at the taluk level hospitals or the district level hospitals or the medical colleges. We have set up the post-COVID clinics in all the primary care centers, the primary health centers, the family health centers, and the community health centers. So initially, the patients will be coming to the primary care centers where they will be screened, and for the issues which can be managed at their level, it will be managed there. And if there are any complications to be managed, they will be referred to the referral clinics which are set up at the taluk level hospital, the district level hospitals, and at the medical colleges. Initially, there is only one day dedicated for the post-COVID OP. Now it is the Thursday. And we are not limiting the service of the post-COVID clinics to the institutions. At the community level, the ASHA volunteers and the health workers are given training. They are trained to visit every house of patients affected with COVID-19, and they will be asking about the red flag signs, and they'll be mobilizing the patients to the post-COVID clinics. So the action actually happens from the community level itself to the primary care centers, and then to the secondary and to the tertiary level centers. So the training has been arranged by the state training division, and it is with this association, in association with the medical colleges and the state medical board, and it is none other than Dr. Aravind who is imparting the training to the medical officers. And we have trained almost all the medical officers across Kerala, ranging from the primary health centers to the district hospitals. And we have also given training to the entire ASHA volunteers, nearly 26,000 of them in the last 1 week time. And now they are ready to go to the community. They will be mobilizing the post-COVID patients to these centers. So it can be a small symptom, or it can be a major symptom, whatever it is. If you are COVID positive, if you are discharged from the hospital, you will be referred, you will be mobilized to the post-COVID center. And there is a telemedicine platform, the eSanjeevani, which is incorporated into the system. So all the patients need not be referred to the taluk level hospitals or the district level hospitals. Only those patients who require emergency care or any specialty care will be referred. And for that, we'll be using the telemedicine network extensively at all these centers. Even the patients can directly contact the doctors, or from the hospitals, they can have the telemedicine chat with the specialists in the taluk level hospitals, district hospitals, and the medical colleges. And those patients who require specialist follow-up, especially the rehabilitation for lung fibrosis or neurological for the stroke syndrome, the cardiology follow-up for the cardiomyopathy, etc., they will be referred to the medical colleges or the district hospitals or wherever the specialist is available. And any patients with the severe complications will be linked to the hospital where they obtain the original treatment. And every patient is registered, they are recorded, because we need this data for a long-term action. Because we are collecting the data of children born to COVID positive mothers. We are collecting the data of children who were found to be COVID positive at any point of the time. Why we are collecting the data is that we need to analyze, we need to know what all post-COVID complications they are going to acquire in a later stage. So we are collecting the data of the antenatal mothers, of the children, and the children born to the antenatal COVID positive patients. And we are linking all these patients to the medical colleges for the tertiary care, and we have pulmonary rehabilitation centers in all the family health centers and in the district hospitals under the COPD control program called the Schwarz clinics. So we have trained our ASHA workers, we have trained our primary care workers in pulmonary rehabilitation, because respiratory medicine is one area which we find most of the patients, and majority of the patients will require pulmonary rehabilitation. So we have given a training on pulmonary rehabilitation to the health workers to be imparted to the patients, whoever need that service. So this slide was previously shown by Dr. Aravind. So we are using the telemedicine platform for risk stratification. Initially, the COVID patient at the community level will be mobilized. And for the red flag signs like dyspnea, palpitation, chest pain, unilateral pedal edema, or syncope, the patients, if they have these symptoms, they'll be referred to the post-COVID clinics in the primary health centers or the family health centers or the community health center. There, the doctor, the medical officer in charge, they will be examining the patient, and those patients who just need some reconciliation, they will be sent back to the hospital after recording all the events. And those patients who require teleconsultation will be consulted with the secondary care centers or with the tertiary care centers. And those patients who really require any additional treatment or any specialty care, they will be sent to secondary care centers or to the medical colleges, depending on their requirement. So this is the algorithm of events that is going to happen. And this is the approach at the PHC or the CHC. The temperature, the heart rate, the rhythm, the blood pressure, the respiratory examination, functional status, pulse oximetry, clinical testing, all will be done at the primary care level. From there, the patient will be sent to either referred to the for medical management or for self-management at their homes or individually. So this is the approach that we have done. And initially, we have started the clinics, a one-day clinic per week. So Thursdays are the days dedicated for the post-COVID clinics. But depending upon the burden of patients going to come, we will be increasing the number of patients, number of clinics from 1 to 2 or 3, depending on the number of patients. So this is the way the Kerala government health services have planned to implement the program in the state. And we are actually not only giving solace to the post-COVID victims, we are also collecting the data of these patients for future use and the future management of the diseases which are going to be a reality. So that's all from the health services department side. And I think Dr. Ashil can add to this in a bigger way. Thank you very much for this opportunity.
Wow, what an elaborate planning actually. Thank you, Bipin. Thank you, Ashil, and the government of Kerala for such an elaborate planning. And we move on to the last speaker, Dr. Kavitha, my dear friend Kavitha, and she is additional professor of pathology in Government Medical College, Ernakulam. Before moving to Kavitha, it's the last speaker, and Madam will finish in a few minutes. And those who want to participate in discussion can press the raise hand button, or you can type on Q&A sessions so that we will allot the questions to the concerned panelist. If you press the raise hand button, we will upgrade you to as a panelist, and you can ask questions. We expect active participation. Over to Kavitha.
Thank you, Dr. Sajeesh, and good evening, everyone. At the outset, I would like to thank the moderator, Dr. Sajeesh, who is my dear friend too, and also Dr. Ajit Kumar, the organizing team leader. I'm here today to share my experiences of my battle with COVID and the post-COVID problems. But before I go on to my experience, let me quote a message which I got just now from a senior doctor. Kavitha, you are going to panic on listening to today's Amuseum. Please think that it's not about you. So that is what I want to tell all the audience, whether they had COVID or they are going to have COVID. Don't panic, especially on hearing my experience and what all the experts have told about the post-COVID syndrome. I would definitely be very truthful, because this narration is in the presence of both the doctors who treated me and helped me bounce back to life, Dr. Aravind and Dr. Fathahudeen. So it was in the first week of August that I was tested COVID positive, and then I admitted to Government Medical College, Trivandrum. And I belong to the category B2 because I already had a comorbid condition, ischemic heart disease with a coronary stent. And I was symptomatic also. So I belong to the category B2, and I received good care and treatment at Medical College Trivandrum with all the drugs the doctors have already described. I was put on steroids and heparin also to prevent clotting of blood. And on the 12th day, when I developed extreme tiredness, loss of taste and with loss of appetite, and also breathlessness, even on the slightest exertion, even after taking a bath. The fatigue was so severe that I couldn't even walk inside the room, and I chose to be on bed most of the time. I always felt confused and was not able to concentrate on anything. I lost interest in all my hobbies, everything I liked the most, like reading and listening to music. And even the ringing of the phone was disturbing, and I felt too low and depressed. I used to convey all these complaints to my doctor, Dr. Aravind, regularly, and he listened to me patiently, giving advices. I must say that this considerate and patient attitude of the treat doctor was the greatest strength I had on those days of suffering. Repeated blood test revealed an elevated liver enzymes too, and that could also have been a cause of my tiredness. I had to take leave for another 2 weeks, and I remained in my room because I was afraid that I would transmit the virus to my family members. But with sufficient rest for another 2 weeks, I regained my energy and I joined duty. But still, I had to be on sedatives because the sleeplessness was severe and it persisted. And on while I was back to routine life at home and at my workplace, I could feel that my energy level was low and I got tired even on the slightest exertion. I also felt difficulty in breathing because I'm a teacher at medical college. While taking classes for 1 hour, I couldn't even take class for 15 minutes and wearing mask continuously. I still thought they were all part of the post-viral illness which could occur after any viral infection. But by the end of the second month after testing negative, the breathing difficulty aggravated so much that people who spoke to me over the phone started asking me, "Are you okay? Are you feeling any breathing difficulty, etc.?" I also developed pain and swelling and redness too in my right leg, and my husband, also a doctor, diagnosed it as deep vein thrombosis, which is a condition where blood clots are formed in the leg veins or leg blood vessels. So Dr. Fathahudeen, I was at Kalamasheri Medical College then. So Dr. Fathahudeen started anticoagulant drugs for me with the clinical suspicion of pulmonary embolism. It is a condition where the blood clots in the leg veins are pushed to the lung veins and causes serious health. On treatment with heparin again, the distress caused by the breathlessness was reduced significantly. And later at Trivandrum Medical College, all the investigations, including a CT chest and a Doppler scan, was repeated. And then I was put on steroids again. And after 1 month of treatment and absolute rest, I'm now feeling better, normal, and I'm active again, except for the severe waves of fatigue I experienced on and off. Even while I was listening, I was in this museum. I got that waves of fatigue 2 times, and then I am not even able to keep my eyes open. But anyway, I am active. I am back to normal. So that is the positive side of it. And I'm so excited that last week I could take classes for 1 hour at a stretch without much difficulty. I'm hopeful that I would overcome this tiredness too and would be back to normal with more vigor. And so as a doctor and a patient who survived COVID and post-COVID syndrome, I would like to convey the message that post-COVID symptoms should never be ignored, because treating them or timely intervention will definitely prevent the complications and restore the quality of your life. Thank you, sir.
Thank you, Kavitha, for first of all exposing your illness for the sake of public that it's not a deadly disease, as is no need to afraid of too much worry about these things. As in many discussions, I always say that we don't, of course, we don't have a single magical bullet, but we have many things to offer, including the critical care and the COVID management. And like in that COVID management, in the post-COVID syndrome also, we have many things to offer. What all things we have so far discussed, what are the ways by which and treatment modalities we can have, and what all strategy we can have in our national level and Kerala, and different strategies, everything we have discussed in. Of course, plenty of things are there, and anything to add, because he is the man behind all the planning of COVID. He is the man actually dissipated the knowledge of fighting against COVID, prevention of COVID, and all. None other than Dr. Muhammad Ashim. Dr. Ashim, please add something further, and some promising thing, promising statements and even slogans. He is very well known for the slogans also, for the slogans for the post-COVID management. Ashim, a few words. After that, we will move on to the Q&A sessions. Ashim, you are muted. Ashim, you are muted.
Thank you very much, sir. But I don't think I deserve many of the titles you have given to me. But still, I would like to continue on what you have ended. Like, as Aravind sir initially put, like, we are actually fighting. Even if the percentage of the population who is going to have post-COVID syndrome is just 2% of the entire COVID positive cases, then our denominator is not 5 lakh. Obviously, our denominator cannot be 5 lakh or 5.5 lakh. Our denominator is much more than that. So our denominator would be, even if we consider that for every case we have detected, we have around, if we look at the serosurveillance data of ICMR, that says that for every 1 case we detect, there is another 10 cases in Kerala. It's the statistics Kerala. When it comes to overall India, it's around 36 cases for 1 case detected and confirmed through RT-PCR or antigen test. So what we're dealing is at least a population of 25 to 30 lakh people who are potentially the denominator of getting into post-COVID syndrome. So I think even the 2% of population would be much higher and much higher than what we actually think of. So not to panic about, but just to have a glimpse of what we are facing or what we are into. I think it's not something which is a kind of a we have precedence of. So and the added feature what we find is that given the epidemiological vulnerability and also the demographic vulnerability we are going through, we have a kind of a one thing which actually struck me when Dr. Maharudra said that it's really affecting the beta cells. So already we are a population with a high prevalence of diabetes. We are a population with a high prevalence of hypertension. And Dr. Bipin sir is dealing with the whole of NCD, whole gamut of NCD over here. So the prevalence of diabetes, just to say a comparison, the prevalence of diabetes is even the lowest prevalence which is estimated in the adult population is around 19% in Kerala. Where I'm sure that Dr. Bipin sir will be having a better statistics of that. So even the lowest prevalence is considered as 19% of adult population is having diabetes. Whereas that of UK, I was having earlier we were having a discussion with a few representatives from UK. So what their prevalence over there is around 6.5% of the population is having diabetes. So just imagine the level of game we are actually playing in. So it would be, of course, it would be a tough time to have. We have a beautiful guidelines after it's drafted. I think one of the best guidelines on post-COVID care and post-COVID as a comprehensive guidelines behind. And I'm sure that team of Dr. Aravind sir is behind that. And I'm sure by that because the Honorable Health Secretary Rajan sir himself said that Dr. Aravind has led the team who drafted the beautiful guidelines for that. So you can't escape of that credit. So then Then we have a beautiful implementation plan and implementation plan. The realm of affairs that is our nodal officer is Dr. Bipin Gopal. In fact, the nodal officer of the entire non-communicable disease. So we have a strong, as Sajeesh sir said, we have a strong system established in that. And to get a slogan, as Bipin sir said, that we are closing the loop of care for COVID-19. So what we're thinking is to close the loop of care for COVID-19. That's why we have planned a title of Revive, so that we actually put it on the even the post-COVID clinics. We are going to name it as Bipin sir yesterday said that it would be like he confirmed yesterday that our post-COVID clinics from now will be named as Revive post-COVID. That we can actually call it as RPCC. So that's it. So I think that the post-COVID clinics in Kerala, and as Honorable Minister has cleared it earlier in her press conference, that the post-COVID clinics here would be only setting the framework for implementation of a major program per se. So we will be having in the days to come, we will be having, of course, we will be having a kind of a post-COVID program per se, where we will be dealing with the issues. As Bipin sir said, we are actually collecting the data of people who are coming to the COVID clinic, and maybe like Bipin sir was saying yesterday, that Dr. Bipin Gopal sir was saying yesterday that he has come across in Wayanad while they conducted a few cases, they examined a few cases. They have come across few bizarre presentations also. So not just the presentations what the symptoms or the issues we have seen in the presentations today. We have come across many more symptoms, and all of us are learning in the way that even and Anthony Fauci once said that nobody is a total expert in COVID-19. So everyone is learning from everywhere. So we must be getting the data, and every day the literatures are being added on. Fathahudeen sir, I must say the one thing that though we have never met, I'm a great fan of you in a way, because Ganesh Mohan usually, who is my senior, usually says about you. So I must say that. And the point sir has mentioned, I think the best point, that is, it's a hit and run. So at least 25 lakh people have hit by COVID-19. At least 25 lakh people. Even the conservative estimate would say that. As the epidemiological data, if you look at, we need to cover around 20-25% people just to see that our plateauing happens. So I'm not going to the estimate of how much would be the 25% of population over here, but still, even if you get the conservative estimate, so that the people of 25 lakh people hit, and now we have to see the consequence of that to happen. So that something that the statement I would like to make is that we are at the beginning of a bigger program per se. I think Bipin Gopal sir would agree to that. We are in the initial phase of a major program to be rolled out, and the Revive post-COVID clinics will be starting for all those things. And with the expertise across the state and the medical board and the team in the state, I think we will be able to set a new standard for treating, because this is a new area. We can actually set a goal and set a model for others to follow also. So that I think would be that would actually bring in a lot of excitement for us, because if a new area explode would actually give an opportunity for committing mistakes and correcting it for ourselves itself. So I think the many nations, we are looking into the experience of many nations which have actually implemented the post-COVID programs. So that will also add to our arsenal. So thank you very much for this opportunity, and I think it's a new beginning for ending the COVID pandemic. Thank you very much.
Thank you, Ashil. You are rightly said. We all are learning. For better learning and better planning, we need queries and questions. And then, if you have questions, we will find out the answers also. So we have a persons in the queue that like Dr. Santosh Kumar and all here he should be a panelist here, but he is there, and we will move to him for his experience. Before that, we weigh more on questions or raise. So those who want to participate, please press the raise the hand buttons. We will upgrade you to the panelist, and we'll allow you to ask questions. Q&A സെഷനിൽ പ്രസ് ചെയ്ത് കഴിഞ്ഞാൽ പാനലിസ്റ്റ് ആയിട്ട് നമ്മൾ അപ്ഗ്രേഡ് ചെയ്യും. അവിടെ നിങ്ങൾക്ക് ക്വസ്റ്റ്യൻസ് ചോദിക്കാം. Maharudra, please bear with us, and some discussions will be in Malayalam. And I request all the panelists to stay back for the queries. And we have a very active participant, that is Miss Bindu. And she is a Bindu Trishurula Asha worker.
Sir, നമുക്ക് കഴിഞ്ഞ ദിവസം ജില്ലാ ലെവലിൽ നമുക്കൊരു പോസ്റ്റ് കോവിഡ് ക്ലിനിക്കിനെ പറ്റി ട്രെയിനിങ് കിട്ടിയിരുന്നു. അപ്പോൾ ആദ്യമായിട്ട് ഞാനൊരു നന്ദി പറയാണ്. കാരണം ഇത്രയും റെപ്യൂട്ടഡ് ആയ ആളുകൾ പങ്കെടുക്കുന്ന ഒരു വെബിനാറിൽ നമുക്ക് ഇങ്ങനെ പങ്കെടുക്കാൻ ഒരു അവസരം കിട്ടിയതിൽ ആദ്യമായിട്ട് ഞാൻ താങ്ക്സ് പറയാണ്. പിന്നെ നമുക്ക് ഈ പറഞ്ഞത് ഇപ്പോൾ കഴിഞ്ഞ ദിവസത്തെ ക്ലാസ്സും ഇന്നത്തെ വെബിനാറും അറ്റൻഡ് ചെയ്യുമ്പോൾ എനിക്ക് തോന്നുന്നു ഇപ്പം നമ്മൾ കോവിഡിനൊരു വാക്സിൻ വന്നാൽ കൂടി നമ്മൾ ഏറ്റവും ജനങ്ങളുമായിട്ട് കൂടുതൽ അടുത്ത ഇടപഴകി താഴെക്കിടയിൽ വർക്ക് ചെയ്യുന്ന ആളുകളാണ് ഞങ്ങൾ ആശാ വർക്കേഴ്സ്. എനിക്ക് തോന്നുന്നു ഇപ്പൊ നിലവിൽ കൊടുത്തുകൊണ്ടിരിക്കുന്ന സർവീസിനേക്കാൾ അധികമായിട്ട് നമുക്ക് കോവിഡ് ഒരു കൺട്രോളിലാക്കാൻ പറ്റിയാൽ കൂടി കൂടുതൽ ആളുകൾക്ക് നമ്മൾ കൂടുതൽ സർവീസ് കൊടുക്കേണ്ട ഒരു ആവശ്യകത വളരെ അത്യാവശ്യമാണ്. എനിക്ക് 2 ക്ലാസ്സുകളും അറ്റൻഡ് ചെയ്തപ്പോൾ എനിക്ക് മനസ്സിലാക്കാൻ കഴിഞ്ഞത്. അപ്പൊ തീർച്ചയായിട്ടും നമ്മൾ കൊടുക്കാൻ പറ്റുന്നതിന്റെ മാക്സിമം സർവീസ് നമ്മൾ ജനങ്ങൾക്ക് എത്തിക്കുന്നുണ്ട് സാർ. ഇപ്പോൾ നമുക്ക് ഇപ്പൊ എന്റെ ഏരിയയിൽ തന്നെ ഒത്തിരി പേര് പോസിറ്റീവ് കേസ് വന്നിട്ടുണ്ട്. അപ്പൊ നമുക്ക് ഫീൽഡിൽ മുമ്പ് കൂടുതലായിട്ട് അഭിമുഖീകരിക്കുന്ന വരുന്നൊരു ചോദ്യം എന്താന്ന് വെച്ചാൽ നമുക്ക് അതായത് പോസിറ്റീവ് ആയിട്ട് നെഗറ്റീവ് ആയ ആളുകൾക്ക് പിന്നെയും അത് വരാനുള്ള സാധ്യത ഉണ്ടോ എന്നുള്ള ആശങ്കയാണ് നമുക്ക് ജനങ്ങൾക്ക് കൂടുതൽ. അപ്പൊ ഇത് വരാനുള്ള സാധ്യത ഉണ്ടോ, അല്ലെങ്കിൽ ഇത് വന്ന ആളുകളിൽ ഇതിന്റെ ഇമ്മ്യൂണിറ്റി എത്ര കാലം നിൽക്കും എന്നുള്ള ഒരു ക്വസ്റ്റ്യൻസ് കൂടുതലായിട്ട് ആളുകളിൽ നിന്ന് നമുക്ക് വരുന്നുണ്ട്. പിന്നെ എനിക്ക് പേഴ്സണലായിട്ട് ഇപ്പൊ ഈ ക്ലാസ്സുകൾ പറ്റുന്നത് എനിക്ക് പേഴ്സണലായിട്ട് എനിക്കൊരു ഡൗട്ട് കൂടി ഉള്ളത് എന്താണെന്ന് വെച്ചാൽ നമ്മൾ നെഗറ്റീവായിട്ട് ഒരാഴ്ച കൂടി അവർ ക്വാറന്റൈനിൽ ഇരിക്കുന്നുണ്ട്. ആ ഒരു ടൈം ഓൾറെഡി അവർക്ക് റെസ്റ്റ് ചെയ്യുന്നുണ്ട്. അപ്പൊ സാറേ അപ്പൊ കൺഫ്യൂഷൻ എന്താണെന്ന് വെച്ചാൽ ഈ ഫിസിക്കലി ഹാർഡ് വർക്ക് ചെയ്യുന്ന ആളുകൾ ഈ ഒരാഴ്ചയിൽ കൂടുതൽ റെസ്റ്റ് ചെയ്യേണ്ട കാര്യം ഉണ്ടോ എന്നുള്ളതാണ് അടുത്തൊരു കൺഫ്യൂഷൻ വരുന്നത്.
ആക്ച്വലി ഇത് വളരെ ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ള കാര്യമാണ്. അത് നമ്മൾ ഈ 7 days റെസ്റ്റിന് ശേഷം ഉടൻ തന്നെ പഴയ ലെവലിലോട്ടുള്ള ഫിസിക്കൽ എക്സർഷനിലോട്ട് ആക്ച്വലി പോകാൻ പറ്റത്തില്ല. അപ്പൊ നമ്മളുടെ സ്റ്റേറ്റ് പ്രോട്ടോകോളിൽ തന്നെ ഗ്രേഡഡ് എക്സർഷൻ ആണ് പറയുന്നത്. അത് പെട്ടെന്ന് മീൻസ് ഒരു ഓടാനോ ചാടാനോ അല്ല വെയിറ്റ് എടുത്ത് പൊക്കാനോ ഒന്നും പറ്റത്തില്ല. ഈ 5 to 10 minutes, പിന്നെ 10 to 20 minutes, 20 to 30 minutes അങ്ങനെ ഗ്രേഡഡ് എക്സസൈസ് പ്രോഗ്രാമിലൂടെ നമ്മുടെ മസിലിന്റെയും അല്ലെ റെസ്പിറേറ്ററി കപ്പാസിറ്റി ഒക്കെ വീണ്ടെടുത്ത ശേഷമേ തിരിച്ചു പോകാൻ പാടുള്ളൂ. അത് നമ്മുടെ ഈ ശബരിമല ഗൈഡ് ലൈൻസിനും വളരെ വ്യക്തമായിട്ട് പറഞ്ഞിട്ടുള്ളതാണ്. നമ്മുടെ യൂസ് ടു അല്ലാത്ത ഇങ്ങനെ ഈ ക്ലൈംബിങ്ങിലോട്ടൊക്കെ വരുമ്പോൾ ഒരു ഗ്രേഡ് എക്സസൈസ് പ്രോഗ്രാമിലൂടെ നമ്മുടെ ഫിറ്റ്നസ് ഉണ്ടെന്ന് ഉറപ്പുവരുത്തിയ ശേഷം മാത്രമേ മോർ എക്സർഷനിലോട്ട് പോകാം.
നമുക്ക് അടുത്ത ക്വസ്റ്റിലേക്ക് കടക്കേണ്ടതായിട്ടുണ്ട്. ഞാൻ റിക്വസ്റ്റ് ഡിവിൻ.
ഹലോ സർ.
ക്വസ്റ്റ്യൻ ചോദിച്ചോളൂ, പെട്ടെന്ന് ചോദിച്ചോളൂ.
എനിക്ക് സാർ 2-3 ചോദ്യങ്ങളാണ്. 2 ചോദ്യങ്ങൾ പ്രധാനം. ഇപ്പൊ പോസ്റ്റ് കോവിഡ് ക്ലിനിക്കിനെ സംബന്ധിച്ച് നമ്മളൊരു PHCയിൽ എങ്ങനെയൊക്കെ വാട്ട് ആർ ദി ഇൻഡിക്കേഷൻസ്, അതായത് നമുക്ക് ഇപ്പൊ അറ്റോക്സബാൻ തുടങ്ങുന്നൊക്കെ പറയുന്നുണ്ട്, അത് എപ്പോ തുടങ്ങാം, നമുക്ക് PHCയിൽ നിന്നും തുടങ്ങുവാണെങ്കിൽ ഇപ്പൊ എന്തൊക്കെ നമ്മൾ അതിനെ ഫോളോ അപ്പ് ചെയ്യണം, അതിന് വേറെ എന്തെങ്കിലും നമ്മൾ പ്രത്യേകമായിട്ട് നോക്കേണ്ടതുണ്ടോ, ഈ അറ്റോക്സബാൻ തുടങ്ങിയ ആൾക്കാർക്ക് അതിന്റെ ഒരു ട്രീറ്റ്മെന്റ്, ഒരു ഗൈഡ് ലൈൻ, അങ്ങനത്തെ ഉള്ള കാര്യങ്ങൾ, ഈ റെഡ് ഫ്ലാഗ് സൈൻസ്. ഇപ്പം എല്ലാവർക്കും ശ്വാസം മുട്ട് എന്ന് പറയുന്നു. അപ്പൊ ആസ്മയുള്ളവരുണ്ട്. അപ്പം വെൻ ടു റെഫർ ടു ഹയർ സെന്റർ, വാട്ട് ഓൾ ക്യാൻ ബി ഡൺ അറ്റ് ദ PHC ലെവൽ, അതൊരു ചോദ്യം. 2ാമത്തെ ചോദ്യം, പോസിറ്റീവ് ആയ ആൾക്കാർ ഇപ്പൊ ശബരിമലയിൽ പോകണമെന്ന് പറഞ്ഞ് നമുക്ക് കുറെ റിക്വസ്റ്റ് ഒക്കെ വരുന്നുണ്ട്. അതിനു മുമ്പ് എന്തൊക്കെ അസസ്മെന്റ് ചെയ്യണം, അതിൽ ഏതൊക്കെയാണ് നമുക്കൊരു ഗ്രീൻ ഫ്ലാഗ് കൊടുത്ത് അവരെ പറഞ്ഞു വിടാൻ പറ്റുന്ന ആരെയൊക്കെയാണ്, അങ്ങനത്തെ ഉള്ള ഇഷ്യൂ. പോസ്റ്റ് കോവിഡ് ക്ലിനിക്കിന്റെ ഇൻഡിക്കേഷൻസ്, അതിനെന്തെങ്കിലും ഗൈഡ് ലൈൻസ് ഉണ്ടോ, അങ്ങനെ പുറത്ത് വിടുമോ, അതൊക്കെയാണ് സാർ എനിക്ക് അറിയാനുള്ളത്. അങ്ങനെ
ഫസ്റ്റ് ക്വസ്റ്റ്യൻ, ഈ ബ്ലഡ് തിന്നേഴ്സ് തുടങ്ങുക എന്നൊക്കെ പറയുന്നത് ടെർഷറി കെയർ ലെവലിൽ മാത്രം നമ്മൾ ചെയ്യേണ്ട കാര്യമാണ്. അങ്ങനെ സസ്പെക്ട് ചെയ്യുകയാണെങ്കിൽ യൂഷ്വലി അവരെ ഒരു 6 മിനിറ്റ് നിങ്ങളുടെ ക്ലിനിക്കിൽ നടത്തി നോക്കുക. അപ്പോഴും ഓക്സിജൻ ലെവൽ കുറയുന്നുണ്ട്, അല്ലെങ്കിൽ അങ്ങനെ ഒരു കംപ്ലൈന്റ് ആയിട്ട് വരുമ്പോൾ നമ്മുടെ ഫ്രണ്ടിൽ തന്നെ നടത്തുക, ലെവൽ ഗ്രൗണ്ടിൽ ഒരു 6 minutes നടത്തുക, റെസ്റ്റിംഗ് ലെവലിൽ ഒരു സാച്ചുറേഷൻ എടുക്കുക. അതൊരു 95 ആണെന്നിരിക്കട്ടെ. ഒരു 6 മിനിറ്റ് നടത്തി അവരുടെ ഓൺ പേസിൽ, അവരുടെ ഓടാൻ പാടില്ല, അവരെ കൊണ്ട് പറ്റുന്ന രീതിയിൽ അവരുടെ ഓൺ പേസിൽ ഒരു 6 മിനിറ്റ് നടത്തിയിട്ട് വീണ്ടും ഒരു സാച്ചുറേഷൻ നോക്കുക. അപ്പൊ അവർ പറയുന്നത് വെറും സബ്ജക്റ്റീവായിട്ട് അവർക്ക് തോന്നുന്നതാണോ, അവരുടെ ആങ്സൈറ്റി കൊണ്ട് ഒബ്ജക്റ്റീവായിട്ട് ഉണ്ടോ എന്നറിയാൻ വേണ്ടിയിട്ടാണ്. ഇതുണ്ടെങ്കിൽ അങ്ങനെയുള്ള ഇപ്പൊ 95 എന്നുള്ളത് 92 ഒക്കെ ആവുന്നു, അതോടൊപ്പം തന്നെ വളരെ കതിച്ചു പോകുന്ന ഒരവസ്ഥ പേഷ്യന്റ് കാണിക്കുകയും ചെയ്യുകയാണെങ്കിൽ നിങ്ങൾ ഒരു ടെർഷറി കെയർ ലെവലിലോട്ട് റെഫർ ചെയ്യാണ് വേണ്ടത്. അവിടെ നമ്മൾ ഫർദർ ഇവാലുവേഷൻസ് ഒക്കെ നടത്തി വീണ്ടും CT സ്കാൻ വേണമെന്ന് നോക്കുന്നു. ചില സ്ഥലങ്ങളിൽ നമുക്കൊരു അഡ്വാൻസ്ഡ് ഡിഫ്യൂഷൻ സ്റ്റഡീസ് ചെയ്ത് നോക്കണം. ഇത്രയും ചെയ്തിട്ട് നമ്മളാണ് തീരുമാനിക്കുന്നത് ഈ ബ്ലഡ് തിന്നേഴ്സ് യൂസ്ഫുൾ ആണോ, അതേ ഒരു വേറൊരു ലെവലിലോട്ട് പോകേണ്ടി വരുമോ എന്നൊക്കെ ആലോചിക്കണം. മറ്റ് ഡിസീസ് റൂൾ ഔട്ട് ചെയ്യേണ്ടി വരും. ഈ ശ്വാസം മുട്ട് പലപ്പോഴും ഉണ്ടാവുന്ന ലങ്സിനോട് മാത്രമാകണമെന്നില്ല. നെഗറ്റീവ് ആയതിനു ശേഷവും പേഷ്യൻസിന് ഹാർട്ടിന് ഈ പ്രോബ്ലം കാണുന്നുണ്ട്. ക്ലോട്ട് ഫോർമേഷനും ECG ചേഞ്ചസും ഒക്കെ വരുന്നുണ്ട്. അതാണോ റീസൺ, അതെ ലങ് തന്നെയാണോ റീസൺ എന്നൊക്കെ അറിയേണ്ടിയിരിക്കും.
പോസ്റ്റ് കോവിഡ് ക്ലിനിക്കിൽ നമ്മൾ പ്രധാനമായിട്ട് നോക്കേണ്ടത് ഹാർട്ട് റേറ്റ്, SpO2 ആൻഡ് മേ ബി പൾസ് റേറ്റ്. അതിൽ കൂടുതൽ എന്തെങ്കിലും നമ്മൾ നോക്കണോ? വേണ്ടല്ലോ.
വേണ്ട.
ഓക്കെ, താങ്ക് യു സർ.
അഡ്വക്കേറ്റ് VR അനിൽ
ഒരു കാര്യം കൂടി ആഡ് ഓൺ ചെയ്യണ്ടേ ബിപിൻ സാർ, ആ ട്രെയിനിങ്ങിന്റെ കാസ്കേഡിംഗ് ഒന്ന് പറഞ്ഞാലേ എനിക്കൊന്ന് ഈ PHC-യിൽ ഇരിക്കുന്ന ഡോക്ടേഴ്സിന് ഇതിന്റെ ഇൻഫർമേഷൻ അതിനെ കുറിച്ച് അതിന്റെ ട്രെയിനിങ്ങിന്റെ കാര്യം ഒന്ന് ജസ്റ്റ് ഒന്ന്.
ഓക്കെ, നമ്മൾ ഓൾറെഡി നമ്മൾ പ്രൈമറി ഹെൽത്ത് സെന്റേഴ്സിലുള്ള ഡോക്ടേഴ്സിന് അരവിന്ദ് സാർ തന്നെയാണ് നമുക്ക് ഡയറക്റ്റായിട്ട് ട്രെയിനിങ് കൊടുത്തിരിക്കുന്നത്. അപ്പൊ അതിൽ നമ്മൾ ഓൾറെഡി പറഞ്ഞിട്ടുള്ള കാര്യം എന്ന് പറയുന്നത് നമ്മൾ പിന്നെ റീഅഷുറൻസ് വേണ്ട ആൾക്കാർക്ക് നമുക്ക് റീഅഷുറൻസ് കൊടുക്കാം. പിന്നെ അതുപോലെ വൈറ്റൽസ് ഒക്കെ നോർമലാണ്, പക്ഷെ അവർക്ക് ചെറിയ കിതപ്പാലുള്ള പ്രശ്നങ്ങൾ മാത്രമേ ഉള്ളൂ. നമ്മൾ പൾസ് ഓക്സിമീറ്റർ വെച്ച് നമ്മൾ നോക്കുമ്പോഴത്തേക്കും ഓക്സിജൻ സാച്ചുറേഷൻ നോർമലാണ്, റെസ്പിറേറ്ററി റേറ്റ് നോർമലാണ്. അങ്ങനെയൊക്കെയുള്ള പേഷ്യൻസ് ആണെങ്കിൽ വി ക്യാൻ ട്രീറ്റ് ദം അറ്റ് PHC ലെവൽ ഇറ്റ്സെൽഫ്. പക്ഷെ അവരെ കോൺസ്റ്റന്റ് ആയിട്ട് ഫോളോ അപ്പ് ചെയ്യുക. പിന്നെ കൂടുതൽ സിംറ്റമാറ്റിക് ആയിട്ടുള്ള ആൾക്കാരാണെങ്കിൽ ആദ്യം നമുക്ക് വേണമെങ്കിൽ നമ്മുടെ ടെലിമെഡിസിൻ നെറ്റ്വർക്ക് വെച്ചിട്ട് വി ക്യാൻ കൺസൾട്ട് എ സ്പെഷ്യലിസ്റ്റ് ഇൻ താലൂക്ക് ഹോസ്പിറ്റൽ ഓർ ഡിസ്ട്രിക്ട് ഹോസ്പിറ്റൽ ഓർ ഈവൻ അറ്റ് മെഡിക്കൽ കോളേജ്. പിന്നെ റിയൽ സിംറ്റംസ് ഉള്ള ആൾക്കാരാണ്, SpO2 കുറവായിട്ടുള്ള ആൾക്കാരാണ്, റെസ്പിറേറ്ററി റേറ്റ് കൂടുതലായിട്ടുള്ള ആൾക്കാരാണ്, അല്ലെങ്കിൽ പൾസ് റേറ്റിന് വ്യത്യാസമുള്ള ആൾക്കാരാണ്, അങ്ങനെയുള്ള ആൾക്കാരാണെങ്കിൽ മാത്രം നമ്മൾ അപ്പോൾ തന്നെ റെഫർ ചെയ്യുക. അതുപോലെ നമ്മുടെ ഈ ആന്റിവൈറൽസ് ഒക്കെ സ്റ്റാർട്ട് ചെയ്യാനായിട്ട് നമ്മൾ PHC ലെവലിൽ പറഞ്ഞിട്ടേ ഇല്ല. അതൊക്കെ ശരിക്കും ടെർഷ്യറി ലെവൽ കെയർ സെന്റേഴ്സിൽ തന്നെയാണ് സ്റ്റാർട്ട് ചെയ്യേണ്ടത്. അത്തരം ഗൈഡ് ലൈൻസ് കറക്റ്റ് ആയിട്ട് തന്നെ നമ്മൾ തന്നിട്ടുള്ളതാണ്.
അഡ്വക്കേറ്റ് VR അനിൽ അൺമ്യൂട്ട് ചെയ്തിട്ട് ചോദിച്ചോളൂ. അനിലേ.
സാർ, എൻ്റെ ഡൗട്ട് നമ്മളിപ്പം ഏസിംപ്റ്റോമാറ്റിക് കോവിഡ് ഡിസീസ് എന്ന് പറയുന്ന പോലെ ഇസ് ദർ എനിത്തിങ് ലൈക്ക് ഏസിംപ്റ്റോമാറ്റിക് ലോങ് കോവിഡ് ഡിസീസ്? അങ്ങനെയാണെന്നുണ്ടെങ്കിൽ വാട്ട് പ്രിക്കോഷൻ ഓർ പ്രിവെന്റീവ് മെഷേഴ്സ് ഷുഡ് ടേക്കൺ ബൈ ദ ജനറൽ പോപ്പുലേഷൻ കൺസിഡറിംഗ് ദ ഫാക്ട് ദാറ്റ് ദർ ആർ ലോട്ട് ഓഫ് അൺഡിറ്റക്റ്റഡ് ഏസിംപ്റ്റോമാറ്റിക് കേസസ് ഇൻ ദ പോപ്പുലേഷൻ?
ഈ എസിംപ്റ്റമാറ്റിക് ആയിട്ടുള്ള ഒരു 30% ആൾക്കാർ ഉണ്ടല്ലോ, അതില് അവരെന്താണ് എസിംപ്റ്റമാറ്റിക് ഇരിക്കുന്ന, യൂഷ്വലി അവർക്ക് നല്ല സെൽ മീഡിയേറ്റഡ് ഇമ്മ്യൂണിറ്റി, അവരുടെ പ്രതിരോധം നല്ല ശക്തിയായിട്ടുള്ളതുകൊണ്ടാണ് അവർക്ക് ആ വൈറസ് അധികം സിംറ്റം കാണിക്കാതെ പോകുന്നതെന്നാണ് നമ്മൾ പഠനങ്ങൾ തെളിയിച്ചിരിക്കുന്നത്. പക്ഷെ എന്നാലും അവർക്ക് ഈ നേരത്തെ പറഞ്ഞ പോലെ ഈ വൈറസ് നമ്മുടെ ഇമ്മ്യൂൺ സിസ്റ്റത്തിനെ എക്സ്പോസ് ചെയ്ത് കഴിഞ്ഞാൽ അത് എന്തായാലും നമ്മുടെ ബോഡിയുടെ ഇമ്മ്യൂൺ സിസ്റ്റത്തിനെ ട്രിഗർ ചെയ്തിട്ടുള്ളതുകൊണ്ട് ഒരു ഹൈപ്പർ കൊയാഗുലബിൾ സ്റ്റേറ്റ് എന്നൊരു സംഭവം ഉണ്ട്. അത് പേടിപ്പിക്കാൻ വേണ്ടി പറയുന്നതല്ല. അതുകൊണ്ട് സിംറ്റം ഒന്നും ഇല്ലാതെ, അതുകൊണ്ടാണ് വളരെ അപൂർവമായിട്ട് നമ്മൾ മനസ്സിലാക്കുന്നത് പോസിറ്റീവ് ആണ്, ഹോം ക്വാറന്റൈനിൽ ഇരിക്കുന്നു, പെട്ടെന്ന് കുഴഞ്ഞു വീണ് മരിക്കുന്ന കണ്ടീഷൻസ് നമ്മൾ കാണുന്നുണ്ട്. അവർക്ക് വേറെ എന്തെങ്കിലും പ്രീഡിസ്പോസിങ് ഫാക്ടേഴ്സ് കാണാതിരിക്കാം, അതല്ലാത്തൊരു ഡെത്ത് ആയിട്ടുണ്ട്. അപ്പോൾ ഇത് പേടിപ്പിക്കാൻ പറയുന്നതല്ല. ഹോം ക്വാറന്റൈൻ ആയാലും ഫസ്റ്റ് ലൈൻ ട്രീറ്റ്മെന്റ് സെന്ററിലൊക്കെ അങ്ങനെ നമ്മൾ കണ്ടുവന്നു. പിന്നെ വെറുതെ സിംറ്റമാറ്റിക് പോസിറ്റീവ് ആണ്, ഒരു സൈഡ് മാത്രം തളർന്നു പോകുന്ന അവസ്ഥ, മോണോപാരസിസ് വരുന്ന ആൾ ഗ്രൂപ്പ്, അല്ലെങ്കിൽ സ്ട്രോക്ക് പോലെ വരുന്ന ഗ്രൂപ്പ് പേഷ്യൻസ് ഉണ്ട്. അപ്പൊ അതുകൊണ്ട് നേരത്തെ ഡോക്ടർ അരവിന്ദ് പറഞ്ഞതുമാതിരി നിങ്ങൾ സിംറ്റം ഉള്ള ആളാണെങ്കിലും ഇല്ലാത്ത ആളാണെങ്കിലും ഗ്രേഡഡ് എക്സസൈസസ് മാത്രമേ ചെയ്യാൻ പാടുള്ളൂ. ജിമ്മിൽ പോവുക, സ്വിം ചെയ്യുക, റണ്ണിങ് ഷട്ടിൽ കളിക്കുന്നു, ക്രിക്കറ്റ് കളിക്കാൻ, അങ്ങനെയുള്ള എക്സസൈഷണൽ പരിപാടികൾക്കൊന്നും ഒരു 4 to 6 weeks പോകാതിരിക്കൽ തന്നെയാണ് ടു ബി ഓൺ ദ സേഫ്. ആസ് വി സെഡ് ഏർലിയർ, നമുക്ക് പലതും ഈ വൈറസിനെ കുറിച്ച് ഇനിയും പഠിക്കാനുണ്ട്, അറിഞ്ഞുകൂടാ. ഇനി 6 മാസം 10 മാസം 2 വർഷം കഴിഞ്ഞിട്ട് ഇതിന്റെ എന്തെങ്കിലും റെസിജ്വൽ സിംറ്റംസ് വേറെ ഏതെങ്കിലും സിസ്റ്റത്തിൽ വരൂ എന്നൊക്കെ പഠനങ്ങൾ നടന്നുകൊണ്ടിരിക്കുക. ഒരുപാട് ഹൈപ്പോത്തസിസ് ഒക്കെ അതിനെക്കുറിച്ച് വരുന്നുണ്ട് ഇപ്പൊ തന്നെ. അപ്പൊ അതുകൊണ്ട് സേഫർ, ടു ബി ഓൺ ദ സേഫർ സൈഡ്, ഒരു 4 to 6 weeks അമിതമായ എക്സസൈസും ചെയ്യാതെ ഗ്രേഡഡ് ആയിട്ടുള്ള കാര്യങ്ങൾ മാത്രം ചെയ്യുക. നല്ലപോലെ വെള്ളം കുടിക്കുക, ഹൈഡ്രേറ്റ് ചെയ്യുക, 8 മണിക്കൂർ ഉറങ്ങുക, മനസ്സ് റിലാക്സേഷൻ, ഇത്രയും വേണം.
Thank you. Then we will move on to Dr. Santosh Kumar SS.
I thank all the panelists for giving such a nice talk, and I'm really delighted to see Dr. Maharudra again. As
Thank you, sir. Thank you very much.
Being like nice to see you again, Dr. Maharudra. So it's like what I would like to say is like it's actually a few questions because I am in a really a controversial situation now. it's rather like I had a myocardial infarction on 30th of last month, and when I had an angioplasty done, and after the angioplasty, I was suspecting because I was suspecting a post-COVID issue. So I did a antibody test. It was positive, and also the D-dimer and the ferritin were also positive. And I didn't have any diabetes or hypertension or any other hypercholesterolemia on that regards. So, but it's like being antibody positive, it could be. But I had no other diseases, like I had no other symptoms of COVID in all these months. Maybe like of course I had a few bouts of like the sore throat and all, which we didn't mind at all. So so what is like it's I don't know, it's like if it's possible for a person to become like to get a myocardial infarction, how many months of this on? So what's really the timeline in which we will classify a post-COVID disease? Dr. Fathahudeen was telling about 1 year. I don't know, it's like if it's 1 year. So do we have a case definition of the time scale in which we will define this disease as post-COVID and non-post-COVID? Because people can otherwise also be, even I said I'm controversial because I have on one side, though I don't have diabetes, hypertension or other one, I might be tempted to say that I'm overweight, and the lack of maybe exercise could be also be contributed, but I don't know if it's possible on that. Second issue is that I had written a article in a paper, in a newspaper, leading newspaper here. So it was so viral, and it's like because most of the people read about it, and they were asking so much of questions. So one typical question was that is like how we even if like if we take the positive cases, the negative, like undiagnosed cases, it could be like 150 times more. It's like 15 to 1 for a single positive cases, we might get 15 non-diagnosed, or maybe even up to 150 non-diagnosis case. So in that case scenario, we know that majority of the people would be unsymptomatic patients. So how would we even diagnose them? So even to how do they suspect them as a post-COVID disease? So don't we need to do a serological analysis, like a big serological analysis, antibody test? And I think once again, because as of now, we don't have much antibody test done, because we have only antigen and the RT-PCR test in our labs. So for diagnosing post-COVID, don't we need to do a lot of antibodies? And in that case, we might need to actually establish a lot of antibody kits. That's a second question I have. Third question is like
Santosh,
can we advise?
brief
last question. Can we actually advise any drugs like aspirin or clopidogrel, or even like the statins? And does these drugs have any role in reducing the post-COVID issue, so that we can actually give blanket or blanket prescription of these drugs? These are the main three questions I have. Maybe people can actually answer such ones. Thank you. I once again thank all the panelists for giving such a nice talk, and also I once again thank Dr. Maharudra for being part of this from Mumbai. Thank you, Dr. Sajeesh.
Thank you, Santosh. Take care.
Yes, Dr. Sajeesh, just I want to opine on a few points about the Dr. Santosh has raised. Yes, Dr. Santosh has raised very good point. Cardiac incidences has been, because I am also COVID positive patient. I have admitted in ICU. I have suffered from myocarditis. Till today, I am feeling exertional breathlessness. I am having bouts of palpitations also, and sudden dyspnea is there, and still I am having late night palpitation episodes. That is also post-COVID, can be classified. But leaving the personal things, personal experiences, yes, Mumbai has reported such a number of incidences in post-COVID stage. People are suffering from cardiac event. It may be ischemic heart disease or MI. Even in COVID, active COVID phase also, there are reported cardiac incidences. One thing. Second thing, Dr. Santosh has raised very good point. We have to promote antibody kit testing so that we will come to know how much population is got exposed, though they are asymptomatic positive or whatever things, but we will get to know the epidemiological survey and statistics about the how much population is got exposed and developed the antibody, which in later on stage we will prepare ourselves for upcoming challenges. Third thing is, very rightly said, in Mumbai, in our post-COVID OPD, we prescribe perfidrone. If is not affordable to the patient, we prescribe them ecosprin for at least 3 months. If he is diabetic, obese, obesity is major factor for the mortality. It's urban, basically urban states, mortality is very high just because of patients are having obesity. And in obese patient, even Dr. Fathahudeen sir may agree, obese patient is really difficult to manage such obese patient because they will not cooperate. At the same time, they will not able to give positive response to the medication and ventilation support. So obesity, that is a major factor which trigger diabetic, hypertensive, cardiac event. So such risk population should be prescribed ecosprin or clopidogrel and atorvastatin. If not affordable, yes, and yes. So this is my opinion, because we are prescribing for at least 3 months and such patient for longer time who have comorbidities, obesities, and these things. Such patients should be kept for a longer period of time on such medications.
Yes, thank you, thank you.
Dr. Santosh, I just want to add one more thing to what Dr. Maharudra said.
Sure.
One is off-label. I am giving aspirin and statin to a lot of patients, especially my doctor populations and their family members, especially if they are smokers above 40 years, family history of coronary artery disease, hypertension, diabetes. They should receive statin for at least 3 to 6 months, along with 150 milligram of ecosprin. Number one. Number two, I have actually described a term called coronary syndrome. I don't know if you've read about it, where active cases coming in the casualty with chest discomfort, COVID positive, you see an NSTEMI or STEMI. We have thrombolized many cases in Pulmonary Government Medical College. They respond very well to thrombolysis, but if you go for an angioplasty, you may end up with catastrophe, because the thrombus you can never remove. You remove it, keep on coming back. You remove it, keep on coming. Don't touch it. Go for a thrombolysis for the time being. Later, you may do an angiogram and fix other vessels. This is number two. Second is COVID negative. What's called swab negative COVID can occur with hyperacute symptoms and cytokine storm, and or they may come in asymptomatic patients later. That must have happened with you. Your COVID antibody titer has gone up, but it has triggered your immune system, which must have caused the, some amount of, in unstable plaque rupture must have occurred. This is the reason. You are obese, but that may not be the reason. The reason is your COVID positivity itself is the trigger, because it might have caused endothelitis, coronary endothelitis. So COVID negative is a big issue. Patient present with cytokine storm, very difficult to convince patients, but antibody test would always help you to prevent litigation also. Thank you so much.
Yeah, thank you. We will move on to next question. Divya, please.
Sir, എനിക്ക് ചോദിക്കാനുള്ളത്, താങ്ക് യു ഡോക്ടർ സജീഷ് സാർ ആൻഡ് അതർ ഡോക്ടേഴ്സ്. എനിക്ക് ചോദിക്കാനുള്ളത്, ഞാൻ ഗവൺമെന്റ് സെക്ടറിൽ ജോലി ചെയ്യുന്ന മെഡിക്കൽ റിപ്പോർട്ട് ലൈബ്രറിനായി ജോലി ചെയ്യുന്ന വ്യക്തിയാണ്. മാത്രമല്ല നമ്മുടെ കലാമേഖലകളിൽ, അതായത് കവിത എഴുത്ത്, കഥയെഴുത്ത്, സാർ ഉൾപ്പെടെയുള്ള നാടക ഫീൽഡുമായി വർക്ക് ചെയ്യുന്ന ഒരു കലാകാരനാണ്. അപ്പോൾ എൻ്റെ സംശയം, എനിക്ക് സിംറ്റം ഇല്ലാതെയും അല്ലെങ്കിൽ സിംറ്റം ആയിട്ടും കോവിഡ് പോസിറ്റീവായ ഒരു കലാകാരനോ അല്ലെങ്കിൽ ഒരു വ്യക്തിയോ അദ്ദേഹത്തിന്റെ കലാജീവിതത്തിൽ ഇനി അങ്ങോട്ട് അത് കഥ എഴുതാനും കവിത എഴുതാനും അല്ലെങ്കിൽ പ്ലാറ്റ്ഫോമിൽ നിന്നുകൊണ്ട് നാടകം അവതരിപ്പിക്കാൻ നടത്തുമ്പോൾ കക്ഷിയുടെ മെമ്മറിയുമായി ബന്ധപ്പെട്ട്, തോട്ടുമായി ബന്ധപ്പെട്ട് അല്ലെങ്കിൽ ചിന്തകളുമായി ബന്ധപ്പെട്ട് ഇനി അതിന് ഒരു വീണ്ടും അത് ആ ചിന്തകൾ, പഴയ ചിന്തകൾക്ക് എന്തെങ്കിലും കോട്ടം സംഭവിക്കുമോ, പഴയ രീതിയിലുള്ള ആ മെമ്മറീസ് അങ്ങനെ തിരിച്ചു കിട്ടുമോ, അത് തിരിച്ചു കിട്ടിയില്ലെങ്കിൽ തന്നെ അത് ചെയ്യാൻ എന്ത് ചെയ്യണം? അടുത്ത ചോദ്യം, ഞാൻ മെഡിക്കൽ റെക്കോർഡ് ലൈബ്രറിയിൽ ആണ് ജോലി ചെയ്യുന്നത്. ഈ മെഡിക്കൽ റെക്കോർഡ് ലൈബ്രറിയിൽ പബ്ലിക് ആയിരുന്നാലും അതുപോലെയുള്ള ബാക്കി ആരോഗ്യ പ്രവർത്തകരും എല്ലാവരും വരുന്ന മേഖലയാണ്. ആ മേഖലയിൽ ഇപ്പോൾ എല്ലാ കേസ് ഷീറ്റുകളും ക്രോണിക്കുമായി ബന്ധപ്പെട്ട് വീണ്ടും അത് റീ അഡ്മിഷന് വേണ്ടി പോയിക്കൊണ്ടിരിക്കുകയാണ്. അപ്പൊ പിന്നെ ഞങ്ങളും ആ മേഖലകളിൽ നിന്നുകൊണ്ട് ജോലി ചെയ്യുന്നവരാണ്. അപ്പോൾ ഇതുപോലെ പോസിറ്റീവ് ആയാലും അല്ലെങ്കിൽ നെഗറ്റീവ് ആയിരുന്നാലും ഈ കോവിഡ് ആയ രോഗികൾക്ക്, ഞങ്ങൾ പോലുള്ളവർക്ക് ഞങ്ങൾ ഇനി ഫർദർ എന്താണ് ഇനി അടുത്ത ടാബ്ലറ്റ് ആയിരുന്നാലും എന്താണ് ട്രീറ്റ്മെന്റ് നടത്തേണ്ടത്, അല്ലെങ്കിൽ ഇനി ഞങ്ങളുടെ അഫക്റ്റ് ചെയ്യാതിരിക്കാൻ അല്ലെങ്കിൽ ഇതിന് ഒരു പ്രിക്കോഷൻ രീതിയിൽ എന്താണ് ചെയ്യേണ്ടത്? ഓക്കെ, താങ്ക് യു സാർ.
ഇത് അങ്ങനെ പേടിക്കേണ്ട കാര്യമില്ല കേട്ടോ. ഇതെല്ലാം ഒരു ഷോർട്ട് ലാസ്റ്റിംഗ് ആണ്. ഇത് നമ്മുടെ ഉദ്ദേശം പേടിപ്പിക്കാവുന്നതല്ലായിരുന്നു. ഈ കൺഫ്യൂഷനൊക്കെ തന്നെ ഒരു ആഴ്ചകൾ അല്ലെങ്കിൽ മാസങ്ങളെ മാക്സിമം നിൽക്കത്തുള്ളൂ. അത് കഴിഞ്ഞ് ഇത് ടോട്ടലി റിവേഴ്സിബിൾ ആണ്. കാരണം ഇതൊരു ഓൺഗോയിങ് ഇൻഫ്ലമേഷൻ ആണ് ബ്രെയിനിലാണെങ്കിലും ഏത് ഓർഗൻ സിസ്റ്റത്തിലും ഉണ്ടാവുന്നത്. ഇത് ടോട്ടലി റിവേഴ്സിബിൾ ആണ്. നമ്മൾ ഈ പറഞ്ഞ റെഡ് ഫ്ലാഗ് സൈൻസ്, അതായത് ലങ്സിനെ ബാധിക്കുന്ന, ഹാർട്ടിനെ ബാധിക്കുന്ന അല്ലാതെ ബാക്കി വരുന്ന എല്ലാം തന്നെ സമയം എടുക്കുമെന്ന് മാത്രമേ ഉള്ളൂ. ആർട്ട് ജീവിതം, കലാജീവിതം ഒക്കെ പഴയ പോലെ തന്നെ മുന്നോട്ട് കൊണ്ടുപോകാൻ പറ്റും. ഒരു കാരണവശാലും പേടിക്കേണ്ട യാതൊരു കാര്യവുമില്ല. ഇത് ഒരു കാര്യം അറിഞ്ഞിരിക്കുക, ഇത് കുറച്ച് നാൾ നമ്മുടെ കൂടെ കാണും. അപ്പൊ ഇനിയും നമ്മൾ മാക്സിമം ഈ പോസ്റ്റ് കോഡ് ഒഴിവാക്കാനുള്ള ഏറ്റവും ഇമ്പോർട്ടന്റ് മാർഗം എന്താണ്? കോവിഡ് വരാതെ നോക്കുക എന്നുള്ളതാണ്. അതായത് നമ്മൾ ഈ പറയുന്ന മാസ്കിങ്ങും ഹാൻഡ് ഹൈജീനും ഒക്കെ തന്നെ നമ്മൾ പാലിക്കുക. വന്നു കഴിഞ്ഞാലും മെമ്മറി ലോസ് ഒക്കെ ഉണ്ടെന്ന് പറഞ്ഞ് ഡിപ്രഷനിലോട്ടൊന്നും പോകണ്ട. ഇതെല്ലാം റിവേഴ്സിബിൾ ആണ്. വീക്സ് ടു മന്ത്സ് കൊണ്ട് ഇത് റിവേഴ്സ് ആവും.
പാനലിസ്റ്റുകൾ എല്ലാവരും, all the panelists please stay back because his time is exceeding, but we have plenty of questions. We'll wind up in 10 minutes. Is it okay? 10 minutes?
ഒരു കാര്യം അറിയണമെന്നുണ്ട്. കാരണം ഇപ്പൊ നമ്മൾ പോസ്റ്റ് കോവിഡ് സർവൈലൻസ് യൂണിറ്റ്സുകൾ അല്ലെങ്കിൽ വെച്ചിട്ടുണ്ട് പലയിടത്തും. അപ്പൊ അതില് ഒന്ന് ഡോക്ടർ ഫത്താഹിനോട് ഒരു ക്ലിനിക്കൽ ക്വസ്റ്റ്യൻ കൂടെയാണ്. ഇപ്പൊ നമ്മുടെ ടെസ്റ്റുകൾ മാത്രമാണ് ചെയ്യുന്നത്. ഇതിനകത്തൊരു ക്ലിനിക്കൽ ഇവാലുവേഷൻ ലൈക്ക് ഒരു എക്സ്റേ എടുത്തിട്ട് അതിന്റെ ഒരു അത് ചെയ്യുന്നത് കൊണ്ട് ഒരു പ്രയോജനമുണ്ടോ ഒരു കോവിഡിന്റെ ടൈമിലും പിന്നെ അതിന്റെ ഒരു ഫോളോ അപ്പ് ആയിട്ടും ചെയ്യുന്നുണ്ട്? അല്ലെങ്കിൽ നമ്മൾ സർവൈലൻസ് ജസ്റ്റ് ക്വസ്റ്റ്യനുകൾ മാത്രം ഒതുങ്ങുമോ, അതോ എന്തെങ്കിലും PFR പോലുള്ള അല്ലെങ്കിൽ ഒരു PFT പോലുള്ള സാധനങ്ങൾ ചെയ്യണോ? ബിസൈഡ്സ് ദ ഐ തിങ്ക് സൈക്കോളജിക്കൽ ഈ ബ്രെയിനിന്റെ എഫക്ട്സ് നമ്മൾ ഡിസ്കസ് ചെയ്തു, ഈ ഫോഗിങ്ങും കാര്യങ്ങളും ഒക്കെ നമ്മൾ ഡിസ്കസ് ചെയ്തു. പക്ഷെ ലങ്സ് ആണ് ഇതിന്റെ അകത്തൊരു ആൾക്കാരെ കുറെ കൂടെ ക്രിട്ടിക്കലായിട്ട് അഫക്ട് ചെയ്യുന്നത്, അവരുടെ പ്രൊഡക്ടിവിറ്റി ഒക്കെ അഫക്ട് ചെയ്യുന്നത്.
നമ്മള് ഈ പൾസ് ഓക്സിമെട്രി കൊണ്ട് ഓക്സിജൻ നോക്കുമ്പോൾ ഓക്സിജൻ നോർമലാണ്, പേഷ്യന്റിന് നടക്കുമ്പോൾ കിതപ്പൊന്നും ഇല്ലെങ്കിൽ എക്സ്റേയുടെ ആവശ്യമൊന്നുമില്ല. എക്സ്റേ കൊണ്ട് നമുക്ക് ആക്റ്റീവ് സ്റ്റേജിൽ, അക്യൂട്ട് സ്റ്റേജിൽ ഡോക്ടറെ അഡ്മിറ്റ് ചെയ്തിരിക്കുന്ന സമയത്ത് ആ സമയത്ത് മാത്രമാണ് ഡീസാച്ചുറേഷൻ ഉണ്ടെങ്കിലോ അല്ലെങ്കിൽ ചുമ നിൽക്കാതെ വരികയാണ്, വേറെ എങ്കിലും സെക്കൻഡറി ഇൻഫെക്ഷൻ സസ്പെക്ട് ചെയ്യണമെങ്കിൽ എക്സ്റേ എടുത്താൽ മതി. സർവൈലൻസിന് വേണ്ടി എക്സ്റേ എടുക്കുന്നതുകൊണ്ട് പ്രത്യേകിച്ച് ഗുണങ്ങളൊന്നും തന്നെ ഇല്ല.
ഡോക്ടർ ശിവകുമാർ. സർ, ആക്ച്വലി ഞാൻ ഡോക്ടർ അഷീൽ പറഞ്ഞതുപോലെ ഡോക്ടർ ഫത്താഹുദ്ദീന്റെയും അരവിന്ദിന്റെയും ഫാൻസ് ആണ് നമ്മൾ എല്ലാവരും. ഇവരുടെ നോളജ് കൊണ്ടാണ് നമ്മൾ ആക്ച്വലി ഞങ്ങളുടെ ഹോസ്പിറ്റലിൽ തന്നെ 621 പോസിറ്റീവ് കേസസ് ഉണ്ടായിരുന്നു. അതിൽ 230 നമ്മള് വീട്ടിലെ ഹോം കെയർ വെച്ചിരുന്നു. ഇപ്പൊ ആക്ച്വലി അതില് നമ്മുടെ 3 മാസമായ കുട്ടികളുണ്ടായിരുന്നു, 8 മാസമായ കുട്ടികളുണ്ടായിരുന്നു, എബോവ് 80 years ഉണ്ടായിരുന്നു, 80 years ഉണ്ടായിരുന്നു. പക്ഷെ അവരെല്ലാം ഇത് കേൾക്കുമ്പോൾ ഇനി ഇവരൊക്കെ മോണിറ്റർ ചെയ്ത് എല്ലാം നെഗറ്റീവായി വിട്ടിട്ടുള്ളതാണ്. പക്ഷെ ചിലർ ഇപ്പോഴും പോസ്റ്റ് കോവിഡ് ക്ലിനിക് നമ്മൾ സ്റ്റാർട്ട് ചെയ്തിട്ടുണ്ട്. ഡോക്ടർ ബിപിൻ പറഞ്ഞതുപോലെ തേഴ്സ്ഡേസിൽ അവിടെ ഇപ്പോൾ റാഷസ് ആയിട്ട് വരുന്നുണ്ട്, സിവിയർ ഫെറ്റിഗബിലിറ്റി കേസ് വരുന്നുണ്ട്, ന്യൂറാലജി ആയിട്ട് വരുന്നുണ്ട്. ഇതെല്ലാം നമ്മൾ സിംറ്റമാറ്റിക് ആയിട്ട് മാനേജ് ചെയ്യുന്നുണ്ട്. പക്ഷെ അതേസമയം നമ്മൾ ഈ ഡിസ്നി ഓൺ എക്സേഷൻ പിന്നെ നേരത്തെ COPD കളൊക്കെ വരുന്നവർ അവര് നമുക്ക് സ്റ്റിറോയിഡ് കൊടുക്കുന്നതിൽ പെരിഫറൽ ലെവലിൽ നമുക്ക് എങ്ങനെ ചെയ്യാൻ പറ്റും? ഡോക്ടർ ഫത്താഹുദ്ദീൻ പറഞ്ഞ പോലെ നമുക്ക് ഗൈഡ് ലൈൻ നമുക്ക് കിട്ടുമോ? അല്ലാതെ നമ്മള് ഒരു ഷോർട്ട് ഡ്യൂറേഷൻ മാത്രം കൊടുക്കുന്ന സിസ്റ്റമാണ് നമുക്കിപ്പോൾ ഉള്ളത്. അതിന് പെരിഫറൽ ലെവലില് സ്റ്റീറോയിഡ്സ് എങ്ങനെ കൊടുക്കാം അതിന്റെ ഒരു ഗൈഡ് ലൈൻ കിട്ടിയാൽ കൊള്ളാമായിരുന്നു. ഡോക്ടർ ബിപിൻ ഗോപാൽ കൂടെ ശ്രദ്ധിക്കുക പ്ലീസ്.
ഡോക്ടർ ശിവകുമാർ ട്രിവാൻഡ്രത്ത് തന്നെ ഉണ്ടല്ലോ. അപ്പോ ബേസിക്കലി ഈ നിങ്ങൾ നേരത്തെ കണ്ടുകൊണ്ടിരിക്കുന്ന COPD ആസ്മ പേഷ്യൻസിനാണെങ്കിൽ ആ ട്രീറ്റ്മെന്റ് ഒപ്റ്റിമൈസ് ചെയ്യുക, അതാണ് ആദ്യം ചെയ്യേണ്ടത്. പലരും ഈ കോവിഡ് വരുമ്പോൾ ഇൻഹേലറൊക്കെ നിർത്തിയിട്ടുണ്ടാവും. അതൊക്കെ റീസ്റ്റാർട്ട് ചെയ്ത് പഴയ ഡോസിലോട്ട് കൊണ്ടുപോവുക. എന്നിട്ട് ആ COPDയുടെ ആസ്മയുടെ കാരണം കൊണ്ടല്ല ഈ ബ്രെത്ത്ലെസ്നെസ് വരുന്നെന്നുണ്ടെങ്കിൽ ഞാൻ നേരത്തെ പറഞ്ഞ ഒരു 6 minutes വാക്ക് ടെസ്റ്റ് പൾസ് ഓക്സിമീറ്റർ ചെയ്യുക. വേറെ ഇൻഫെക്ഷൻസ് ഒന്നും ഇല്ല എന്ന് ഉറപ്പുവരുത്തുക. ഒരു സെക്കൻഡറി ഇൻഫെക്ഷൻസ് ഒക്കെ വരാം ഈ പേഷ്യൻസ്. ഇതൊന്നും ഇല്ലാന്നുണ്ടെങ്കിൽ പ്രത്യേകിച്ച് ഒന്നും ചെയ്യണ്ട. അഥവാ ഈ ഡീസാച്ചുറേഷൻ ഉണ്ട്, അത് നമ്മുടെ നേരത്തെ ഉള്ള COPD ആസ്മ കൊണ്ട് അക്കൗണ്ട് ചെയ്യാൻ പറ്റുന്നില്ല, നിങ്ങൾ ഒപ്റ്റിമൈസ് ചെയ്തിട്ടും പറ്റുന്നില്ലെങ്കിൽ ഒരു ഹയർ സെന്ററിലോട്ട് വിടുക. അല്ല, നിങ്ങൾക്ക് ഈ പേഷ്യന്റിനെ ഇൻസൈഡ് ഔട്ട് അറിയാമെന്നുള്ളതാണ്, മറ്റു കോമോർബിഡിറ്റീസ് ഒക്കെ നല്ലതുപോലെ അറിയാവുന്ന നിങ്ങൾ തന്നെയാണ് അതൊക്കെ മാനേജ് ചെയ്യുന്നത്. അങ്ങനെ ആണെങ്കിൽ അറ്റ് യുവർ ലെവൽ നിങ്ങൾക്ക് തന്നെ ഒരു ഷോർട്ട് കോഴ്സ് സ്റ്റിറോയിഡ് കൊടുക്കുന്നതിൽ തെറ്റില്ല. അത് ഗൈഡ് ലൈനിൽ അങ്ങനെ പറയാൻ പറ്റാത്തതുകൊണ്ടാണ് അത് പറയാത്തത്.
Your class is always practical. Thank you.
Okay. സുഞ്ജിത്ത്, ഷീന, നമ്മൾ വൈൻഡ് അപ്പ് ചെയ്യാണ്. സുഞ്ജിത്ത്, ഷീന, സാജൻ, ജയശ്രീ ആരെങ്കിലും ലൈനിലുണ്ടെങ്കിൽ ആർക്കെങ്കിലും ചോദ്യം ചോദിക്കുകയാണെങ്കിൽ ചോദിക്കാം. Can ask questions. റോഷൻ ബാലകൃഷ്ണൻ ആരുമില്ല എന്ന് കരുതുന്നു. ഓക്കെ, we are winding up.
ഒരു കാര്യം പറഞ്ഞോട്ടെ.
ഓക്കെ,
അതായത് നേരത്തെ ഒരാൾ ചോദിച്ചൊരു ചോദ്യമുണ്ട്, ഇതിന്റെ ഗൈഡ് ലൈൻസ് എവിടെ കിട്ടുന്നില്ല. നിലവിലുള്ള പോസ്റ്റ് കോവിഡ് ക്ലിനിക്സിന്റെ ഗൈഡ് ലൈൻസ് 28-ാം തീയതി അപ്ലോഡ് ചെയ്തിട്ടുണ്ട്. അത് അവിടുന്ന് ഡൗൺലോഡ് ചെയ്യാൻ പറ്റാവുന്നതാണ്. ഒരു 28 പേജുള്ള ബ്യൂട്ടിഫുൾ ഗൈഡ് ലൈൻസ് അതിൽ അരവിന്ദ് സാറെ കൂടി ഉണ്ടാക്കിയ ഒരു ബ്യൂട്ടിഫുൾ ഗൈഡ് ലൈൻസ് ഉണ്ട്. ആ ഗൈഡ് ലൈൻസിനകത്ത് നമുക്ക് എന്തൊക്കെയാണെന്നുള്ളതിനെ കുറിച്ച്, പോസ്റ്റ് കോവിഡ് ക്ലിനിക്കിൽ എന്തൊക്കെയാണ് നടക്കുന്നത്, എങ്ങനെയാണ് നടക്കുന്നതിനെ കുറിച്ച് ഗൈഡ് ലൈൻസ് ഉണ്ട്. അതെല്ലാവരും കാണുക. ഒന്ന്. രണ്ടാമത്തെ കാര്യം, നേരത്തെ സന്തോഷ് സാർ ചോദിച്ച കാര്യം, അതെല്ലാം കൂട്ടി വായിക്കുമ്പോൾ നമുക്ക് എപ്പോഴാണ് ഒരു പോസ്റ്റ് കോവിഡിൽ അറിയണമെങ്കിൽ, അതായത് ഇത്രയും ആൾക്കാർക്ക് എത്ര പേർക്ക് കോവിഡ് ഉണ്ടായിട്ടുണ്ട് എന്ന് അറിയില്ലല്ലോ. കണക്ക് പറഞ്ഞാൽ നമ്മൾ 5 ലക്ഷം എന്ന് പറയുമ്പോഴും വലിയ ശതമാനം ആളുകളിൽ ഒരുപക്ഷെ കോവിഡ് വന്നു പോയവരുണ്ടാവും. അവർക്കും പോസ്റ്റ് കോവിഡിന്റെ സാധ്യത ഉണ്ട് എന്നുള്ളത് കൊണ്ട് ഞാൻ നേരത്തെ സൂചിച്ചപ്പോൾ 25 തൊട്ട് 30 ലക്ഷം ആളുകളുണ്ട്. അപ്പൊ അവരിലേക്ക് എങ്ങനെയാണ് നമ്മൾ സീറോ പ്രിവലൻസ് സ്റ്റഡി എന്ന് പറയുന്നത്? സീറോ പ്രിവലൻസ് സ്റ്റഡി കേരളം ICMR ഇപ്പോൾ ഒരു റൗണ്ട് ഓഫ് സീറോ പ്രിവലൻസ് സ്റ്റഡി നടത്താൻ പോവുകയാണ്. കേരളത്തിലും നമ്മൾ ലോക്കലായിട്ട് സീറോ പ്രിവലൻസ് സ്റ്റഡി നടത്താൻ വേണ്ടി പോവുകയാണ്. ഓൾറെഡി നടക്കുന്നതിന് കുറച്ച് കാര്യങ്ങൾ കൂടി നടത്താൻ വേണ്ടി പോവാണ്. ICMRന്റെ സഹായത്തോടു കൂടി നടത്താൻ വേണ്ടി പോകുന്നുണ്ട്. അപ്പൊ അതുകൊണ്ട് സീറോ പ്രിവലൻസ് നടക്കും. പക്ഷെ അതുകൊണ്ട് മാത്രം നമുക്ക് മനസ്സിലാക്കാൻ വേണ്ടി പറ്റില്ല. ഒരു എന്തൊക്കെ ഇപ്പം ഹാർട്ട് അറ്റാക്ക് ഇപ്പൊ ഉണ്ടാവുന്നു, കഴിഞ്ഞ കൊല്ലം ഹാർട്ട് അറ്റാക്ക് ഉണ്ടായിരുന്നു, ഇക്കൊല്ലം ഹാർട്ട് അറ്റാക്ക് ഉണ്ടാവുന്നുണ്ട്. അപ്പൊ എത്ര ആളുകളാണ് കോവിഡ് മൂലമുണ്ടായ ഹാർട്ട് അറ്റാക്ക് കൊണ്ട് മരിച്ചെന്ന് അറിയണമെങ്കിൽ അതിന് നമ്മൾ എക്സസ് ഡെത്ത് അനാലിസിസ് എന്ന പരിപാടി ചെയ്യാനുണ്ട്. ആ എക്സസ് ഡെത്ത് അനാലിസിസ് ചെയ്യുമ്പോൾ മാത്രമേ നമ്മൾ മനസ്സിലാവുള്ളൂ കഴിഞ്ഞ കൊല്ലത്തെക്കാളും ആപേക്ഷികമായിട്ട് ഈ വർഷം എത്രത്തോളം മരണങ്ങൾ ഇതുമായിട്ട് ബന്ധപ്പെടുത്താൻ സാധിച്ചു. അങ്ങനെ വന്നതിൽ മാത്രമേ നേരത്തെ സന്തോഷ് സാർ സൂചിപ്പിച്ച പോലെ ചോദ്യം ഉണ്ടാവുള്ളൂ. നമുക്ക് ഭാവിയിൽ വരുന്ന ഇപ്പൊ ഈ കേരളത്തിൽ 2020 എത്ര അസുഖങ്ങൾ, എത്ര ഹാർട്ട് അറ്റാക്ക്, എത്ര സ്ട്രോക്ക് ഇതുമായിട്ട് ബന്ധപ്പെടുത്താൻ പറ്റുമെന്ന് നോക്കണമെങ്കിൽ എക്സസ് ഡെത്ത് അനാലിസിസ് ചെയ്ത് അതിന്റെ കൺഫൗണ്ടേഴ്സിനെ മാച്ച് ചെയ്ത് ഒരുപക്ഷെ നമുക്ക് അതിന്റെ റിസ്ക് ഫാക്ടേഴ്സിന് ഒരു മൾട്ടിവേരിയറ്റ് ലോജിസ്റ്റിക് റിഗ്രഷൻ ഒക്കെ നടത്തിയിട്ട് വേണം അനലൈസ് ചെയ്യാൻ വേണ്ടി. സോ ദാറ്റ് വിൽ ടേക്ക് ടൈം. ബട്ട് ഫോർ ഓൾ പബ്ലിക് ഹെൽത്ത് ആക്ടിവിറ്റി പലപ്പോഴും നമ്മൾ ഡെത്തുമായിട്ട് ഡോക്യുമെന്റേഷൻ അടക്കം ഒരു കൺഫ്യൂഷൻ ആണ്. നമ്മൾ പബ്ലിക് ഹെൽത്ത് ആക്ടിവിറ്റീസിന് വേണ്ടി വെദർ കോവിഡ് പോസിറ്റീവ് ആണ് ഡെത്ത് കണ്ടെത്തി കഴിഞ്ഞാൽ വി ആർ ആക്ച്വലി ക്യാരിങ് ഔട്ട് ദ പബ്ലിക് ഹെൽത്ത് ആക്ടിവിറ്റീസ്. വെദർ ദാറ്റ് ടു ഇൻക്ലൂഡ് ഇൻ ദ കോവിഡ് ലിസ്റ്റ് എവറിത്തിങ് ദാറ്റ് ആക്ച്വലി ഡിപെൻഡ്സ് അപ്പോൺ ലോട്ട് ഓഫ് ഡാറ്റ. നമുക്ക് എത്ര കാലം ഇനി വന്ന ഹാർട്ട് അറ്റാക്കുകളിൽ എത്ര കോവിഡ് ആയിട്ട് ബന്ധപ്പെടുത്താൻ വേണ്ടി പറ്റും എന്നുള്ള കാര്യങ്ങളൊക്കെ ഭാവിയിൽ നോക്കേണ്ടി വരുമ്പോൾ എക്സസ് ഡെത്ത് അനാലിസിസ് വുഡ് ഓൾസോ ഹെൽപ്പ്. അപ്പൊ 2 things, സീറോ പ്രിവലൻസ് സ്റ്റഡി ആൻഡ് എക്സസ് ഡെത്ത് അനാലിസിസ് ഈസ് ഗോയിങ് ഓൺ ഇൻ കേരള ആൻഡ് acting actually will contribute a lot in science, knowing much about the science of COVID-19 here.
Yes, we have to conclude and concluding. Last, any panelist, any and before that I'll just kind of make some notes, and after that you can any addition you want you can add on that. Just COVID is not just a viral fever, it's a thrombotic event. So wherever there is a blood vessel, then we can have thrombosis. So it can affect any system, whether it's in the COVID phase or in the post-COVID phase. Another major area is that asymptomatic patients. Whether we have in asymptomatic COVID patients, we can have antigen testing and RT-PCR testing and so many testing, and we can have strategies. Symptomatology. We can have we can grade symptomatology and all. Likewise, we should formulate Ashil and Aravind and Fathahudeen and all should be concentrated on that. Post-COVID also, or COVID asymptomatic also, we should be able to categorize on the symptomatology point of view, and serology, that's a seroprevalence study, of course, like antibody, there we have antigen and anti-RT-PCR, here we have to concentrate on antibody plus symptomatology, and in even some high-risk patients we have to identify with the NCD when Bipin is there, so you know better. So, I mean, you have the better data of NCD data. You take the NCD data, non-communicable disease data, and all those. You pick up the patients, identify those high-risk patients, and you have to screen them. And even if they are not on aspirin or atorvastatin and all, we have to start them on that. It's a big task. Actually, this is a post-COVID clinic and post-COVID activities. But unfortunate thing is, in one seminar, actually, Aravind was saying that in a study class, actually, that's the most common, around 80% symptom is fatigability. But it's a very fake symptom. And how, even in the criteria wise, if you add fatigability, we make a huge load on healthcare workers to identify, screening on the post-COVID issues. You have to rely on, we have to rely mainly on the telemedicine, on cut short the initial screening, and then we have to, because fatigability, if you miss the fatigability as a symptom on our inclusion criteria, then we will lose the very healthy, productive, and 30 to 50-year-old age group cardiac patients also. Not only the respiratory point of view, lung patients, but we may miss the cardiac patients. And my experience in Mumbai and all for the last 6 months is that most of the cardiac events, of course, we can have a myocarditis is notorious for most of the viral fever, but we can have a conduction abnormalities. In ICU, all the patient, every other patient have an arrhythmia. Without arrhythmia in intensive care, no patient is there. We have some atrial fibrillation or some, conduction block, so some kind of arrhythmia maybe there at the duration course of this thing. Of course, it's due to the ischemia. Of course, it's a hypoxia, and hypoxia adding to the inflammation. It's a vicious cycle actually. So even in the post-COVID also, these kind of events can happen. But in the coronary, as we have discussed, it's a coronary event. As Fathahudeen is rightly pointed out, and I am also convinced that it's more of an unstable angina picture rather than a supply-demand mismatch. Stable angina, it's more of an unstable angina, endothelial damage, and platelet aggregation, and add on to that existing condition. This is a situation. A lot of work we have to do on the post-COVID. Aravind and all of the panelists, we will continue on this thing in different forums. Thank you all the panelists, and I invite Amuseum trustee Ajit Kumar for the vote of thanks. Thank you all once again for the elaborate discussion presentation and showing your patience for all the Q&A sessions, even though I'm sure that we exceeded around half an hour, but I think it's productive. Thank you, Kavitha and all.
Thank you, Sajeesh. We are going to wind up this session.
Yes, Sajeesh.
Thank
you, Ajit.
We have to give a big thanks to the attendees. We have actually crossed our capacity, and many people called us that they can't join the webinar through the Zoom. So people are actually viewing through the Facebook only. So they can't directly ask questions through the interaction session. That's one thing we missed. But we have the chat box and question answer session. We copied all these things. So I think we will continue with the questions, and we'll try to find out the answers, and we'll try our best to reach the answers to the public. Secondly, I would like to thank Dr. Santosh Kumar A, Dr. Muhammad Ashid, Dr. A. Fathahudeen, Dr. Aravind A, Dr. Kavitha Ravi, Dr. Maharudra, Dr. Bipin Gopal, who were the eminent panelists in this session. Also, Dr. Sajeesh for moderating this session wonderfully. And also, Amuseum would like to thank Kerala Social Security Mission for supporting our project. I think through our association, we are actually outreaching our scientific programs to the public more with the Social Security Mission support. Thank you, Dr. Muhammad Ashid and Kerala Social Security Mission. With that, we are winding up this session, and good night for all. Thank you.